Ma'am, please start. Thank you.
Good afternoon, everybody. I am Dr. Jayashree Deshpande, President, Palghar Academy of Pediatrics. I welcome you all on this Brain Power Bonanza. It is my pleasure to introduce our first speaker, Dr. Nilesh Palwankar. Dr. Nilesh is a sincere, down-to-earth pediatrician from Virar. He is widely respected for his hard work and deep knowledge and experience in this field. Today we will learn hyperglycemia in newborn from him. Please welcome Dr. Nilesh Palwankar sir. Dr. Nilesh, you can share the slides now.
Yes, and kindly unmute yourself, sir.
Yeah.
Thank you.
Video on. Madam, can I start?
Yes, sir.
Sir,
Please
you
start.
Can everybody hear me?
Yes, we can hear you.
Okay. So first, I would like to thank Dr. Jayashree Deshpande, Dr. Anudhada Palwankar, and all Palghar Academy of Pediatric members to give me this opportunity to talk on today's topic. So always we keep talking about hypoglycemia in newborns, and we know so much about hypoglycemia in newborns. So I thought let us talk something about the hyperglycemia in newborns. As a neonatologist, you may come across hypoglycemia very frequently, but as a pediatrician, as a neonatologist, you may come across hyperglycemia not frequently, but when you come across, and if your sugars are very high, like in range of 400 and 500, then you realize, I forgot how to manage the hyperglycemia. Now what to do? Then you call up someone, and then he says, okay, you start with insulin drip, and then you are stuck up. What to do now? So I thought, let us have some discussion regarding hyperglycemia in newborns. Definitely, I am not going to talk about neonatal diabetes mellitus. That topic I have taken out completely because it is altogether different discussion, and it will be a very lengthy topic if I take that into consideration. So hyperglycemia in newborns without neonatal diabetes mellitus. So we'll start our discussion. So before I start my discussion, I just want to go through some calculations, some important calculations, what we do day in, day out. But I think it is better to just brush up those calculations. If you read literature regarding the glucose in Western country, they will talk about the millimoles per liter. In Asian country, we'll talk about milligram per deciliter. So always we think, so what is the calculation? The calculation is very easy. 1 millimole per liter of glucose equivalent to 18 milligram of deciliter of glucose. So if they say ki my glucose is 5 millimoles per liter, it means 18 into 5. So that is 90. If my glucose, if they say ki it is 10 millimoles, so 10 into 18. So that is 180. So this we have to remember, because in many of the literatures, they will talk about the millimoles. The correction factor is we multiply it by 18. So second, we have to understand glucose infusion rate that we do in and out. So there are two formulas. First formula is percentage of dextrose being infused to the baby into rate, that is ml per hour, divided by body weight into 6. So this is little lengthy. Some units may be following this, but I personally go with simpler formula, that is IV rate, that is ml per kg per day into dextrose, because on day 1 we give 60, on day you give 80, day 10 you give 100. So it becomes easy. Then percentage of dextrose divide by 144. So whatever is the formula, your GIR will be like 4 milligram per kg per minute, 6 milligram per kg per minute, 8 milligram per kg per minute. You have to maintain somewhere between 4 to 6 milligram per kg per minute. Now, when you are dealing with hyperglycemia, then you should know what is your GIR. If you don't know your GIR, then it becomes difficult to give the fluid concentration. So there is another formula, like in standard we give what we give. We give 10% dextrose, we give 5% dextrose, and we give isop. So now if you want to give 7.5, if you want to give 6, if you want to give 8% of dextrose, then you have to know this next formula. So that is desired glucose concentration. Now in market you are having 5% dextrose, you are having 10% dextrose, you are having 25% dextrose. So with these three things, you have to make a desired concentration. Now some units, they go with 10% dextrose and 25% dextrose. Some units, they go with 5% dextrose and 25% dextrose. I personally go with 5% and 25%. So what is the formula? Formula is simple. 5x minus 25 is equal to ml of 25% dextrose. You have to add to make a solution of 100 ml. Suppose I have to give 7% of dextrose. So 5 into 7. So that is 35. Okay. So 35 minus 25. So that is 10. So now I will take 10 ml of 25% dextrose and 90 ml of 5% dextrose to make 7% of dextrose. So this calculation is very important. So this calculation, if you keep doing, then you will realize that you can make 6.5, 7, 8, 8.5 according to your GIR. Suppose if you want GIR of 8, then accordingly you can make your calculation like 5% and 10%. But if you want somewhere in between 7.5, so this formula is important. But what you have to understand, this calculation is only for 100 ml. You have to make 100 ml of solution, and according to that you have to adjust your IV fluids. So I'm very clear. First is 1 millimole of glucose is 18 milligram, then GIR and desired concentration. These three formulas you should know if you are dealing with the case of a hyperglycemia. Now we'll move ahead. So how we do blood glucose monitoring? Like in olden days, glucose measurements were done with dextrose sticks. They thought it is non-invasive, do it better, but high possibilities of inaccuracies are there. So nowadays we have move on, and then we are doing capillary blood. But serum glucose is approximately 15% higher than the capillary blood. So if I do a capillary blood, suppose if it is 100, then the serum glucose will be around 115. So if it is around 200, my capillary blood glucose is 200. So my serum glucose will be 230. So if you are suspecting hyperglycemia, don't rely on the strip. You have to do proper serum glucose level before you initiate the treatment of hyperglycemia. So in some units in Western country, they go with urine glucose measurement by using reagent strip. Why they are important? You will come to know in the next slide. So this table will tell you on left side the grading of the strip, and on the right side these are correlating with the glucose level in the blood. So if my strip is showing grade 0, my glucose is less than 100 milligram per deciliter. Grade plus or minus, it is 100 to 250. If it is grade 1 plus, my glucose level is 250 to 500. If it is grade 2, it is 500 to 1000. If it is grade 3, 1000 to 2000, and if it is grade 4, more than 2000. So if the child is having neonatal diabetes mellitus, your sugar can go up to 1000, 2000. So this is very simple way to understand what is your blood glucose level. So this is the chart which will help you to tell approximately what will be your glucose level. So these are the few tips which are important when you deal with the case of a neonatal hyperglycemia. So now we will start with the theoretical discussion. So first I will like to do introduction. So for practical management purpose, blood glucose is around 70 to 150 milligram per deciliter. It is taken as a safe range. Hyperglycemia, like if you search the literature, they will say 125 milligram per deciliter of whole blood, or plasma glucose more than 145 milligram per deciliter. So I think what we do is the plasma, what we do in our side lab. Blood glucose more than 180 to 100 milligram of deciliter are of concern in neonates. So when it is more than 180 to 200, you have to start intervening. Now, why it is important? Osmolarity of more than 300 milliosmol per liter usually leads to osmotic diuresis. Each 18 milligram per deciliter rise in a blood glucose concentration increases serum osmolarity to 1 milliosmol per liter. Like if you can't say ki माझं glucose 250 पण बाळ तर चांगलं आहे. No. If your glucose is high, it means it is a hyperosmolarity situation, and if it goes more than 300, the child will have diuresis, and then child will lead with intracranial hemorrhage. So you have to be very careful if your sugars are going up like 250, 300, 350, 400. You have to start acting, otherwise hyperosmolar state will give problem to the brain. A glucose level more than 450 to 720 milligram per deciliter can cause water to move out from intracellular compartment to the extracellular compartment. The resultant contraction of the intracellular volume of the brain may be cause of an intracranial hemorrhage. So we are really worried about this part. If your glucose is unchecked and if it goes very high, then there are chances of IC bleed. So we differentiate hyperglycemia early onset, like within 48 hours of life. So everybody of us has come across this situation where the glucose was high initially and then eventually it settled down. What we are really talking about a late onset, where you see a high level of glucose even after 48 hours. So how we do grade the hyperglycemia? Mild, it is between 150 to 180. Moderate hyperglycemia is 180 to 270. And severe hyperglycemia is above 270 milligram per deciliter. So now let's talk about etiology and some pathogenesis. How and what are the causes? The etiology, as everybody of knows, one is prematurity. When we deal across extremely preterm babies like 23 weeker, 24 weeker, microprimaries, definitely we come across with hyperglycemia, and then that is the reason we start with 5% dextrose and not with the 10% dextrose. Every one of us has come across a child who was severely IUGR and his sugars were in the range of like 200, 250 to begin with. Hypoxia and seizures. This is very common presentation. You get a child with HI stage 2, stage 3, and sisters keeps calling, sir, sugar high, sugar high. You just tell her, then you say, okay, tu zara tham, sugar hoil coming. And then after 6, 12, 24 hours, you start realizing now sugars are coming down. Sepsis, as you know, whenever the sugars are very high, we have to think of a sepsis, and we have to rule out blood culture, and we have to do blood culture, procalcitonin and other parameters. Definitely fungal infection, you have to think if the hyperglycemia is persistent. Intravenous fluid, definitely if you start 10% dextrose in microprimaries, your sugars are going to be very high. Lipids. So if you give lipids on a like 3 gram per kilogram per day, definitely your sugars can be very high. Now neonatal drugs. So what are the drugs? Catecholamines like dopamine, dobutamine, they are responsible. Like you can start, if you start with adrenaline, noradrenaline trip, it can cause caffeine, theophylline, and phenytoin. These are the few drugs which give rise. Definitely, antenatal steroid can also contribute to the neonatal hyperglycemia. Then another category are maternal drugs. Suppose mother is on some medication, and definitely there can be rise in the sugar level. So that you have to take a good maternal history and to understand whether it is contributing to the hyperglycemic state of the newborn. What is the pathogenesis in nutshell of a hyperglycemia newborn? It is very simple. First, it is increased counter-regulatory hormones. So, like if in a sepsis or in hypoxia, seizure babies, you will see this phenomena, increased counter-regulatory hormones, and which settles down with time. Decrease insulin release. This you will see basically in IUGR babies. And reduce peripheral utilization of glucose. This you will see mainly in the premature and IUGR babies both. So, this is the etiology and pathogenesis. Now I would like to talk about, we know so many things about hyperglycemia, but we cannot forget about glucose transporters. So there are basic two glucose transporters. So whenever the insulin binds to the receptor, there are glucose transporters which transpose glucose from the extracellular compartment to the intracellular compartment, and that's why your blood glucose comes down. So these two receptors plays, I won't say receptors, transporters play very important role. So in this figure you can see the insulin sugar is there, insulin is released, and glucose transporter 2, there is an influx of sugar from the extracellular compartment to the intracellular compartment. So this is glucose transporter 2. Similarly, there is glucose transporter 4, GLUT, GLUT4. Again, the insulin binds to the insulin receptor. Now, this glucose transporter 4, that is GLUT4, will again transport glucose from extracellular compartment to the intracellular. Then why we are talking about GLUT2 and GLUT4? Because GLUT2 and GLUT4 are the main factors why there is a decreased peripheral utilization of the glucose in the preterm and IGR babies. So these figures are very important that you can keep in mind. That is GLUT2 figure, and this is GLUT4. So because we are going to come across the discussion, these two transporters. So this is important if you want to go into detail. Central and peripheral glucose insensitivity and insulin resistance. That is the reason why we come across hyperglycemia, the child who is not having sepsis. Okay. Now, a healthy adult glucose infusion, like if you give a glucose infusion to the adult, that is around 6 milligram per kg per minute, completely suppress the endogenous glucose production. समजा मी एखाद्या माणसाला ग्लुकोज दिलं ऍडल्टला 6 मिलीग्राम पर केजी पर मिनिट, त्याचं ग्लुकोज प्रोडक्शन थांबणार आहे. बट इन preterm neonate glucose production is not suppressed in the same way by the glucose infusion. Studies in the newborn have shown glucose level can reach up to 250 milligram per deciliter. म्हणजे जोपर्यंत तुमचं शुगर 250 होत नाही त्याचं एंडोजिनस प्रोडक्शनच कमी होत नाही. और you have to give GIR 16 milligram per kg per minute before glucose production is suppressed. So what we have to understand, it requires high glucose to suppress the endogenous production. Inverse is what? Inverse, unless and until you reach 250, the endogenous production is not going to suppress. So if my sugar is 200, it is not going to suppress the endogenous production. That's why the insulin comes into the picture, to reduce the endogenous glucose production or to increase the peripheral utilization. That we have to understand. इन्सुलिन द्यायचं पण इन्सुलिन द्यायची गरज का आहे? कारण त्यांचं एंडोजिनस ग्लुकोज प्रोडक्शन जे सप्रेस व्हायला पाहिजे ऍडिक्वेट शुगर दिल्यानंतर ते होत नाही, किंवा पेरिफरल युटिलायझेशन होत नाही. दॅट्स वाय वी हॅव टू गिव्ह इन्सुलिन अँड वी हॅव टू कम ओव्हर द क्रायसिस. See, this this whatever I am talking about, central and peripheral glucose insensitive and insulin resistant, this may be in part due to immature expression of GLUT, that is glucose transporter, particularly GLUT2 and GLUT4. तर तुमचे GLUT2 आणि GLUT4 इमॅच्युअर असतात, जे ग्लुकोज एक्स्ट्रा सेल्युलर मधनं इंट्रासेल्युलर घेऊन जाणार आहेत. सो बेसिकली बेबी इज इमॅच्युअर. That's why the glutes are also immature, and that's why their sugars are high. The less abundant insulin sensitive tissue. So if you see IUGR baby, if you see microprimes, then there is a less of adipose tissue, less of the skeletal muscle, which are having insulin sensitive tissues. They are less. Definitely, so sugar is there, but adipose tissue is not there. Skeletal muscles are not there. So where the insulin is going to act? At the same time, GLUT2 is expressed in the muscles, and the muscles are less. That's why the insulin cannot mediate the glucose transport in the preterm babies. So that we have to understand. First, immaturity of the GLUT transports and the scarcity of the adipose tissue and the skeletal muscle. So what is relative insulin deficiency? Again, immaturity of the beta cells. So this is different. Immaturity of the beta cells may result in insufficient insulin secretion. GLUT2 transporters are involved in glucose stimulated insulin secretion from the pancreas, but fetal pancreatic beta cell do not express GLUT2 until 7 months, impacting on the beta cell response to hyperglycemia. आता शुगर लेवल हाय झाली, तर बीटा सेल्स ऍक्टिव्हेट व्हायला पाहिजे ना. बीटा सेल ऍक्टिव्हेट होऊन त्यांनी इन्सुलिन द्यायला पाहिजे, पण ते करताना GLUT2 तयारच झालेले नसतात. आता GLUT2 तयार न झाल्यामुळे बीटा सेल इन्सुलिनच सेक्रेट करत नाही. सो बेसिकली वी हॅव टू अंडरस्टँड दिस सायकल. देन वी नो की अरे वाय देर इज अ हायपरग्लायसिमिया. वी ऑलवेज थिंक की नाही, फक्त स्ट्रेस रिस्पॉन्स आहे, होईल कमी, इन्फेक्शन आहे, होईल कमी. पण सपोज देर इज अ एंडोजिनस प्रोडक्शन ऑफ द ग्लुकोज, हाऊ यू आर गोइंग टू कम ओव्हर. सपोज GLUT2 GLUT4 एक्सप्रेसच झाले नसतील बेबीमध्ये, किंवा तुमचं मसल कमी आहे, ॲडिपोज टिश्यू कमी आहे, then how you are going to tackle. Don't see hyperglycemia only for sepsis, don't see hyperglycemia only for hypoxia and convulsions. नाही, hypoxia असेल रे, convulsion असेल, शुगर जास्त आहे. No, you have to think a decreased peripheral utilization and GLUT2 and GLUT4 ची immaturity. Then you will think, no, I have to think of insulin. Otherwise what you will do, you will just keep postponing. थांब रे बघूया, and by the time the sugars are 400 and 500. So that you have to keep in mind. It is not only the stress, it is the GLUT2 GLUT4. At the same time, immaturity of the beta cells may also play a role in your baby, other than sepsis and hypoxia and stress. That I want to emphasize. Preterm infants are often also growth restricted. So some preterms are IUGR. So they are associated with म्हणजे बीटा सेल मासच कमी आहे, बीटा सेलच इमॅच्युअर आहे, तो डेफिनेटली इन्सुलिनचा इश्यू येणार. द लेवल ऑफ प्रो इन्सुलिन आर हाय इन प्रीटर्म निओनेट, suggesting that processes of pro-insulin into insulin is also effective. Now beta cells काय करतात, pro insulin असतं, they convert it into insulin, but because prematurity they cannot convert pro-insulin into insulin. So it is not only the stress factor and the sepsis, the pro-insulin, then less beta cell mass, immaturity of the beta cells, immature GLUT2 and GLUT4, they are also important for the hyperglycemia. Please come out of that. नाही रे stress असेल, नाही रे sepsis असेल. No, you have to think this part also. So if we don't take care of the hyperglycemia, समजा 150 आहे, 200, 250 आहे, and if you don't look at it, so what may can happen? Okay, a missile is behind you and this is the jet. You have to find the answer. You can't just overlook ठीक है, आ रहा है रे, पीछे से जाने दो. No. You have to take steps. So what are the clinical consequences? Everybody knows, I am just going through it. Initial transient hyperglycemia may be physiological and beneficial in acute stress, but if it is prolonged, then it is associated with poor prognosis. So if it like 6 hours, 12 hours, 24 hours, 36 hours, you can overlook. But if it is more than 36 hours, 48 hours, it can be detrimental to the baby, especially in microprimies and extreme preterm severe IUGR. Many preterm morbidities are, as well as mortality are associated with increased hyperglycemic exposure. Don't feel sugar जास्त आहे तर काय फरक पडत नाही. Definitely it is going to take toll on baby's internal milieu. Hyperglycemia can lead to osmotic diuresis, just we discussed. It can lead to hypernatremia and electrolyte imbalance, and it has been associated with intraventricular hemorrhage. The shrunken brain can give rise to the intraventricular hemorrhage. In some, if you search the literature, they say that hyperglycemia is associated with retinopathy of prematurity, chronic lung disease, necrotizing enterocolitis, reduced white matter in the brain tumor. Now they are postulating high sugar. They lead to some changes in the translocation of the E. coli, and they can get more activated, and they lead to the NEC. So that is also papers are coming up, NEC and hyperglycemia. So basically what we have to think, osmotic diuresis होणार, weight loss होणार, आणि baby will land into a problem. That like ROP, CLD, NEC, these are not very much confirmed. These are just observation. But I personally feel ki weight loss and hyperosmolar state are going to be very difficult. And if you just overlook, then you may land up with DIC. Like hyperosmolar state राहिली फार वेळ, तर definitely sluggish blood circulation होणार, आणि then you may land up with DIC also. That you have to be careful. So now a few tips for all of us. Not very great, everybody knows about it. Just I will go through quickly. Dextrose concentration less than 5% and GIR below 4 milligram per kg per minute are not recommended in the management of hyperglycemia. If 5% dextrose किंवा 4 milligram per kg per minute देऊन सुद्धा sugar control येत नाहीये, then you don't have any other option but to start thinking about the insulin. Avoid GIR more than 15 milligram per kg per minute, as this may promote excessive lipogenesis causing abnormality in the liver enzyme. Like some people, they start with TPN आणि मग त्याच्यामध्ये लक्षातच येत नाही की GIR जास्त आहे. But if you GIR is unknowingly more, then it is going to be a problem to the liver enzyme. So if you are doing total TPN, you be careful what sisters are doing. Suppose तुम्ही जे कॉन्सन्ट्रेशन बनवायला गेला 12.5%, त्याच्यामध्ये तुम्ही 5x आणि -25 ने कॅल्क्युलेशन करायला गेलात आणि सिस्टरने उलट केलं, तर डेफिनेटली युअर GIR विल बी व्हेरी हाय. So you have to be very careful regarding these calculations. Sorry. Insulin, see, this is very important. Insulin infusion tubing should be filled and kept for 20 minutes for the insulin to get absorbed to the plastic walls of the intravenous tubing to avoid initial medication failure. You can't put insulin and immediately you cannot start. Those insulin will get stuck to the plastic tubings आणि मग let them saturate. एकदा ते सॅच्युरेट झाले ना, then only the insulin will go. Otherwise what will happen, you will start the drip is very slow, and whatever insulin is there, it is going to stick to the tubing. You imagine ना, तुमची 10 ml ची 15 ml ची सॉरी 5-6 ml तर 2-3 ml तर असतंच, 100 सेंटीमीटरची ट्यूब घेतली आणि तुम्ही स्टार्ट केली, सपोज 1 ml per hour. I am just telling you, imagine how much amount of insulin is going to stick. सो तुम्हाला ती पूर्ण करावी लागेल, ड्रिप तयार करावी लागेल, आणि ती ड्रिप तयार केल्यानंतर 20 मिनिटं ठेवावं. ही प्रॅक्टिकल टिप सिस्टरांना देणं गरजेचं आहे. तुम्ही इन्सुलिन समजा 500 ml NS मध्ये टाकलं आणि ते 20 मिनिटं ठेवलं आणि नंतर IV फ्लुइड लावून चालू केलं, नाही चालणार. जे काय तुम्ही चालू करताय ना, ते IV फ्लुइडला स्टिक होणार. तर तुम्हाला ते IV फ्लुइडच्या टिप पर्यंत आणायचं तयार केलेलं, आणि नंतर 20 मिनिटं थांबून मग तुम्हाला चालू करायचं. सी, दिस इज व्हेरी इम्पॉर्टंट. अदरवाइज यू विल स्टार्ट स्ट्रगलिंग. अरे मी तर इन्सुलिन चालू केलंय, शुगर का कमी नाही झालं. सो दॅट यू हॅव टू टेल सिस्टर्स की तू 50 युनिट इन्सुलिन 500 ml NS मध्ये टाक, तू ती IV फ्लुइडच्या शेवटपर्यंत आण, त्याच्यानंतर 20 मिनिटांनी आपल्याला चालू करायचंय. This is very crucial. A small thing, but very big impact. Prophylaxis, insulin is not recommended. Routine insulin infusion for the prevention of catabolic is not recommended. Like if you see a catabolic state in very severe IUGR, you cannot see no catabolic state is there, I will use insulin because it is anabolic. No, it is not recommended. Catecholamine infusion and glucocorticoids treatment could be limited or stopped as soon as the infant circulation has improved. Early protein intake by parenteral infusion is recommended. Increased lipid infusion decreases insulin function to inhibit the glucose production, leading to hyperglycemia. So you cannot go like Western literature, they say you can go 3 grams per kg per day, but I'm worried. Nutrition with great proportion of protein and less fat and carbohydrate has been recommended to have a better blood glucose stabilization with less frequent episode of hyperglycemia. I think everybody of us now they are doing like protein and sugar. I don't know about fat. Personally, I don't use fat, so I don't know about my colleagues whether what is their experience regarding hyperglycemia and TPN, total TPN. But yes, definitely protein amino vein, use of a amino vein also limit. See, you have to understand amino will limit. But suppose if your sugars are in the range of 500 and 600, don't expect that amino vein is going to, yes, it will have smooth control, but it cannot decrease the hyperglycemia. That you have to understand. So these are the practical tips for, like you say, minute adjustment. But if you have to do major adjustment, it will be done with insulin only. Early oral feeding should be encouraged. So now intervention. So what are the different interventions if the child sugar is very high? So now you have to go ahead with intervention. So what are the interventions? Clinical interventions for the management of hyperglycemia. First, Asfagan and Aspen guidelines clearly advise avoiding glucose more than 145 or 150. आपल्या इथे आपण 200-250 पर्यंत ऍक्शन घेत नाही, कारण मे बी वी डील विथ अ हायपॉक्सिक चाइल्ड, स्ट्रेसफुल चाइल्ड, अँड विथ 12 hours 24 hours द सिच्युएशन्स कम इन टू कंट्रोल. मिकोनियमचं बेबी आहे, त्याचं पण शुगर हाय असतं, त्याला डोपाडोपिटामिन ड्रिप चालू असते, त्यामुळे त्याचे शुगर हाय असतात. बट व्हॉट recent guidelines they see, you have to take consideration into 145 to 150. Maybe they are dealing with more cases of microprimies and extreme prematures, and they are not dealing with meconium aspiration and birth asphyxia, what we are dealing with. Optimizing amino acid intake and the use of insulin has the theoretical potential to improve lean body mass and pancreatic function. So in short, if you use amino acid, definitely rather than fat, a muscle mass will increase, and definitely it will improve the pancreatic function. Excess rate clearly associated with hyperglycemia, but the impact of lower rate of glucose infusion are more nouns. म्हणजे तुम्ही लोअर ग्लुकोज वापरायला जाऊ नका, नाही रे हायपरग्लायसिमिया होईल. सो देर आर टू सिच्युएशन. 10% एक्स्ट्रोज मी देतो आणि त्याचा हायपरग्लायसिम होईल, आणि आय स्टिक टू 5% ग्लुकोज टू अवॉइड हायपरग्लायसिमिया. सो दॅट इज मोर डेट्रिमेंटल. Like sticking to 5% dextrose all the time can be a more detrimental rather than using 10% dextrose and keeping the child on the higher side. So lower rates are not good. At lower GIR, the influence of differences in the other compartment of parenteral nutrition may play an important role. म्हणजे सांगायचं तात्पर्य काय, टीपीएन मध्ये तुम्ही शुगर पण देणार, तुम्ही कार्बोहायड्रेट तुम्ही कार्बोहायड्रेट देणार, फॅट देणार आणि तुम्ही प्रोटीन देणार. त्या तिघांचं इंटरॅक्शन हे वेगवेगळं असू शकतं डिपेंडिंग अपॉन द कॉन्सन्ट्रेशन ऑफ शुगर अँड फॅट अँड प्रोटीन्स यू आर गिव्हिंग. सो दॅट यू हॅव टू कीप इन माइंड. ठीक आहे, म्हणजे तुम्ही थिअरॉटिकली बरोबर कॅल्क्युलेशन केलं पाहिजे. माझा जीआय आहे, माझं कॉन्सन्ट्रेशन आहे, माझा हा रेट हे आहे, माझं मी प्रोटीन एवढं देतोय, मी माझं फॅट एवढं देतोय, त्याप्रमाणे आता माझं सगळं होईल असं नाहीये. यू हॅव टू कीप इन थॉट की माझं जे मी जे ऍड केलेलं आहे अमायनो वेन किंवा जे मी फॅट ऍड केलेलं आहे, इट कॅन अफेक्ट माय ग्लुकोज युटिलायझेशन अँड इट मे हॅव बोथ द वेज लोअर अँड अप्पर लेवल ऑफ अ ग्लुकोज. सो दॅट यू हॅव टू बी व्हेरी केअरफुल. म्हणजे तुम्ही सगळं बरोबर लिहिलेलं आहे ऑर्डर मध्ये, ग्लुकोज किती, फॅट किती, प्रोटीन किती, आणि तुमच्या कॅल्क्युलेशन प्रमाणे ते मॅनेज होईल असं नाहीये. सो यू हॅव टू बी व्हेरी केअरफुल when you are doing TPN, total parenteral nutrition. So that you have to keep in mind. Amino acids stimulate insulin secretion. Low plasma arginine level have been associated with hyperglycemia. Suppose there are some नको रे मला अमायनो वेन पण द्यायचं नाहीये, then obviously insulin secretion will be less. There is no arginine definitely. Then the chances of hyperglycemia are more. So it is better you use partial TPN. Neonates receiving amino acid infusion in addition to glucose have higher insulin levels. A Cochrane meta-analysis conclude that higher amino acid intake in PN was associated with reduction in hyperglycemia. This is simple way. You add protein, you add amino acid, you add amino vein. This is the simple way. Insulin is altogether different. पण जे तुमचं शुगर आहे 200-250च्या रेंज मध्ये, जे तुम्हाला 180-140 आणायचं आहे, सो putting a child on partial TPN is a simpler way. So you can start with 0.5 gram per kg per day, then you can step up to 1 gram, then you can step up to 1.5 gram, you can go to up to 2 gram per kg per day. Slowly also you can go ahead. Some people, they say you start directly with 3, some say they you start with 2. I personally go with 1 or 0.5, then next day I go to 1, then next to next I go to 1.5. Never go more than 2 gram per kg per day. Lipid infusions may have a beneficial effect by reducing the glucose load. Obviously तुम्ही लिपिड दिलं तर ग्लुकोजची गरज कमी असते. By reducing the glucose load while maintaining energy intake, they can reduce the prevalence of a hyperglycemia. So you are using less dextrose. However, in excess or in acute illness, lipids have been reported to contribute to hyperglycemia. So this is double-edged weapon. Like it can help to prevent hyperglycemia, but then if you don't look at the other side of the baby, then it may lead to hyperglycemia also. Esfagan recommends parenteral glucose intake किती पाहिजे, ideal parent glucose intake किती पाहिजे, 4 to 8 milligram per kg per minute on day 1 and rising to 8 to 10 milligram per kg per minute over the subsequent 2 to 3 days. So you can go up to 8 to 10 milligram per kg per day. What this आपण usually 4 to 6 मध्ये असतो, but they are telling you should go up to 8 to 10 milligram. But definitely you have to see to that your sugars level are not more. So this is the recommendation for better weight gain. Both Esfagan and American Society of Aspen recommend maintaining GIR 180 milligram per deciliter. It is then recommended that insulin treatment should be started. म्हणजे Western countryचा cut off 180 आहे. In some literature I have read in their unit they will not start before 250. I personally I also wait till 250. 250च्या वर असेल, 6-12 तासांनी सुद्धा जास्त असेल, then only I think of insulin. Otherwise I don't think of insulin. 180 वगैरे यायला बहुतेक आपले सेटअप आणि आपले सिस्टर्स आणि आपल्याला जो काय वेळ द्यायचा आहे ना त्या पेशंटसाठी, तो बहुतेक आपल्यासाठी पुरेसा नाहीये. म्हणून आय पर्सनली फील मोर दॅन 250 then you should start thinking about the insulin. Less than 250 you manage with amino vein, you can manage with lesser concentration of the IV fluid, then you look after the medication part, and then you try to reduce the stress of the baby and you keep checking the sugar level. But yes, if it is more than 250-300, you cannot say ki nahi ajun mi thamto. At least you start preparing your calculations. नाही लागले तर उत्तमच आहे. So now we are actually coming to the treatment part. So आतापर्यंत it was like hitting around the bush. हिंदी पिक्चरचा सिनेमा, आजूबाजूला फिरतायत बगीचात. So now it is the actual treatment part. I think this is going to be very crucial for any one of us. If you are in NICU and you are in the night duty and sugars are in 500, who is going to pick up your phone call? So better we at least know how you have to go ahead. What is the role of insulin? Challenges in insulin treatment is preterm babies relate to the combination of rapidly changing insulin sensitivity, the difficulty of consistent in insulin delivery, and lower frequency of glucose monitoring. Now there are monitors which monitor the glucose for 24 hours. See, every word is important. Insulin sensitivity keeps changing in the baby every day, every hour. The insulin sensitivity, take it from me, the insulin delivery, what we say theoretically, is practically very, very difficult when you come to the level of the system. So this is real challenge, or difficulty of consistent insulin delivery. Hyperglycemia itself causes insulin resistance, and following increasing insulin to regain the normoglycemia, insulin requirements often fall, and there is an increased risk of hyperglycemia. असं नाही आहे की मी इन्सुलिन दिलं आणि मी आता सीझर कॉलला गेलो, मी आता जेवायला गेलो, मी आता रात्री झोपलो, मी आता उद्या सकाळी बघतो. नो, बिकॉज व्हॉट हॅपन्स वन्स यू स्टार्ट इन्सुलिन ना, द इन्सुलिन रेझिस्टन्स जो असतो ना तो कमी होतो आणि फटाफट जे शुगर एक्स्ट्रा सेल्युलर ते इंट्रासेल्युलर जातं. and if you keep giving the same insulin, then you may land into hypoglycemia. So that you have to की नाही मी एकदा चालू केलं तर आता 6 तास तरी मला काय काळजी नाही. The picture can change after 3 hours also. Then your calculation should be ready. Insulin is easily absorbed onto the intravenous line, and the use of large volume syringe for delivery at small infusion rate make insulin delivery very unpredictable. You imagine ना, तुम्ही एवढा मोठा इन्फ्युजन पंप वापरणार, सॉरी सिरिंज पंप वापरणार, 20 ml ची सिरिंज वापरणार, 10 ml ची सिरिंज वापरणार किंवा 50 ml ची सिरिंज वापरणार, त्याच्यामध्ये एवढा मोठा एक्सटेन्शन 100 सेंटीमीटरचा वापरणार, तो डेफिनेटली इन्सुलिन इज गोइंग टू स्टिक टू इट. Although if you say ki I will keep for 20 minutes for the saturation. So these things you have to keep in mind ki insulin delivery is very, very tricky. So definitely two modes, conservative and medical therapy. Everybody likes conservative, including me. So conservative always better, but sometimes you have to go with medical therapy. You don't have option in life. Conservative management, what we do day in day out for so many years. Primary focus on reducing GR to target levels, minimizing trigger factors, adequate supportive care to minimize the stress, and to provide adequate caloric intake. हे आपण knowingly करतो. बट मेडिकल थेरपी इज प्रोव्हाइडेड विथ इन्सुलिन बोलस अँड इन्फ्युजन ट्रीटमेंट. आता तुम्हाला एक लक्षात घ्यावं लागेल की इट इज नॉट नेसेसरी की हायपरग्लायसिमिया म्हणजे मला आता इन्सुलिनची ड्रिप चालू करायची. नो, देअर कॅन बी सिच्युएशन वेअर शुगर इज युअर 400 and with your insulin boluses it can come to normal. So before starting infusion of insulin, you have to give 3 doses of insulin bolus. समजा एक डोस मध्ये तुमचं शुगर नॉर्मल आलं, then you can start with your routine management. तुम्हाला 2 डोस लागले आणि त्याच्यात तुमचं शुगर नॉर्मल आलं, you can come back to your normal management. तुमचं तिसऱ्यांदा तुम्ही बोलस दिला आणि त्याच्यानंतरही शुगर नॉर्मल नाही आली, नाव यू हॅव टू गो विथ इन्फ्युजन. समजा मी तिसरा बोलस दिला आणि आय कम बॅक टू नॉर्मल स्टेटस, येस आय कॅन गो टू माय रुटीन मॅनेजमेंट, बट आफ्टर थर्ड you have to start with the infusion. Okay, babies are initially given 5 to 8 milligram per kg minute of intravenous glucose to maintain normal blood glucose level. Ata usually we have to do the blood glucose level every 4 to 6 hourly. If blood glucose sugar is more than 145, then urine should be tested for sugar. मी तुम्हाला जी दाखवली ना strip, here it will come into the picture. When glycosuria is more than 1, there is a risk of increasing osmolality causing osmotic diuresis and weight loss. समजा एका बेबीचा weight loss होते, you can just put that strip in the urine and then you will come to know नाही my sugars are high, 2 दिवस झाले weight loss होते. You cannot prick the baby all the time. You take the strip and check. If it is high, then this is the reason, and then you can go with the serum glucose. Conservative treatment should be initiated if RBS leading should, हे थोडंसं चुकलं. Conservative treatment should be initiated if reading is more than, बरोबर आहे, more than 180, 10 millimoles. So practically in India, I feel 250 is okay. But I don't know. It is everybody's choice. Avoid excessive intravenous fluid drugs and rule out sepsis that causes hyperglycemia. Blood sugar should be frequently monitored. Now, if your sugar is more than 180, then you have to go 1 hourly or 2 hourly. If blood sugar is still more than 180, then GIR should be reduced gradually to minimum 4 milligram per kg per minute and dextrose concentration to 5%. आता समजा माझी शुगर 250 आहे, कितीपर्यंत मी खाली आणू शकतो? माझा GIR मी 4 मिलीग्राम पर केजी पर मिनिट पर्यंत खाली आणू शकतो आणि माझं कॉन्सन्ट्रेशन आहे ते मी 10 वरनं 7.5 7.5 वरनं मी 5 वर आणू शकतो. अदरवाइज आय कॅन ब्रिंग टू सी. व्हॉट इज द मिनिमम is GIR 4 and concentration is 5. ह्याच्या खाली तुम्हाला जाता येणार नाही. ह्याच्यानंतर इन्सुलिनच पिक्चर मध्ये येणार. Insulin therapy is initiated when the blood glucose is more than 200. 200च्या वर तुम्ही इन्सुलिन चालू करा किंवा इन्सुलिन चालू करायचा विचार करा किंवा तुमचे कॅल्क्युलेशन्स तयार ठेवा आणि देवाला प्रार्थना करा की शुगर कमी येऊ दे. दॅट्स आय पर्सनली फील बिकॉज इट इज नॉट इझी जॉब दॅट यू विल कम टू नो. नेक्स्ट स्लाइड्स. Insulin bolus. So I talk, you can give 3 boluses of insulin. Insulin bolus 0.05 to 0.1 unit per kg IV can be given over 15 minutes and check blood glucose after 30 to 6 minutes. शुगर माझी 250 आहे, मी इन्सुलिन दिलं किती 0.05 to 0.1 unit over how much time? 15 minutes. I checked. Okay, I can do it 3 times. Maximum of 3 boluses are suggested every 4 to 6 hours. If the blood glucose level remains high, इन्सुलिन इन्फ्युजन इज इनिशिएटेड. ठीक आहे, म्हणजे मी 3दा देऊ शकतो पण आयव्हीज द्यायचंय, सबक्यूटस नाही. नाही तर आपल्याला बऱ्याच काय वाटतं की ऍडल्ट मध्ये जसं देतात देऊन टाक रे 5 युनिट सबक्यूट. नो, इवन इफ इट इज बोलस you have to give IV. So now different unit can have different calculation. I cannot go in detail because of the time constraint. The initial starting dose of insulin doses is between 0.01 to 0.05. Imagine the micro calculation. 0.01 to 0.05 units per kg per hour and gradually increase up to maximum rate of 0.1 units per kg per hour. So these are very complex calculation, but in short, you start with 0.01 to 0.05 and maximum you can go to 0.1. Okay, suppose the child is of, suppose for practical purpose 2 किलोचं बाळ, तर मी मॅक्सिमम किती देऊ शकतो? 2 युनिट देऊ शकतो दर तासाला, म्हणजे पूर्ण दिवसात मी 24 युनिटच देऊ शकतो. ओके, मॅक्सिमम. लोअर डाऊन तर थिंग्स आर डिफरंट. सो दीज आर द मायन्यूट कॅल्क्युलेशन्स. Frequent blood glucose monitoring is essential during insulin infusion to maintain glucose between 150 to 200. बरं ठीक आहे रे, तुम्हाला सांगितलं जातं ग्लुकोज आणायची, मग किती पर्यंत आणायची? 150 ते 200 पर्यंत आणायची. 150च्या खाली गेले की देवाचे आभार मानायचे आणि आपलं रुटीन मॅनेजमेंट चालू करायचं. बट व्हॉट इज युअर टार्गेट? टार्गेट इज बिटवीन 150 to 200. Tighter glycemic control aiming for glucose values far below 150 increases the risk of hypoglycemia. नाही रे 120 येऊ दे, मग 80 येऊ दे. नो, less than 150 you start with your routine management. Now stepping up and stepping down दोन्ही slowly व्हायला पाहिजे. You can increase the speed, but I feel you should not miss the step. तुम्हाला इन्सुलिन वाढवायचं असेल हळूहळू वाढवा आणि कमी करायचं असेल ना तर हळूहळू कमी करा. एकदम वाढवलं एकदम कमी केलं ना तर मग आयदर यू विल लँड अप विथ द हायपरग्लायसिमिया और यू विल लँड अप विथ द हायपोग्लायसिमिया. ओके, सो यू हॅव टू डू इट व्हेरी ग्रॅज्युअली. The insulin infusion should be tapered gradually. Insulin infusion can be discontinued where the glucose level remains stable at or below 150. Stable म्हणजे काय? ऍटलीस्ट 6 ते 12 तास ते 150च्या आसपास असेल, 3 to 6 hours, then you can discontinue. What are the complications? Everybody knows, like hypoglycemia and hypokalemia. For hypoglycemia 2 cc per kg standard. For hypokalemia there is a double correction, triple correction, single correction. depending upon your why there is hypokalemia. Insulin जेव्हा act होतं ना तेव्हा it will take calcium and it will take potassium also inside, so your potassium can fall down, so that's why you have to take care of your potassium also. So with in nutshell, so this is the chart. I am not going to go through this chart because there is same repetition. So if it is more than 10, what you have to do, if it is more than 10, first तुम्हाला जे काय तुम्ही रुटीन मॅनेजमेंट करता, मेडिसिन बघा, हे बघा, ते बघा, त्याच्यानंतर तुमचा GIR कमी करा. हे नाही झालं तर देन यू गो टू इन्सुलिन बोलसेस 3 वेळा इन्सुलिन बोलसेस देऊन सुद्धा तुमची शुगर 200च्या वर असेल, देन यू हॅव टू स्टार्ट विथ द insulin drip. On the right side, they have given beautiful chart. Insulin bolus therapy followed by insulin infusion damage. So this is very complex. It will take 1 day to make you understand and then to do the calculation. I tried to do it, but then I think it is way beyond our online. ऑफलाईन मध्ये तरी थोडंसं पॉसिबल आहे, पण ऑनलाईन मध्ये सगळे बंपर जातील. त्यामुळे मॉरल ऑफ द स्टोरी हेच आहे की जर तुमचं शुगर 200च्या वर असेल, यू कीप युअर कॅल्क्युलेशन्स रेडी फॉर इन्सुलिन बोलस अँड इन्सुलिन इन्फ्युजन. अँड देन यू स्टार्ट टॉकिंग विथ युअर सिस्टर्स की शुगर 250च्या वर आहे, बहुतेक मला इन्सुलिन लागेल, तर तुम्हाला इन्सुलिनचं अरेंजमेंट करावं लागेल. तुम्हाला तसे कॅल्क्युलेशन जे आहेत ते लिहून काढावे लागतील. लिहून काढल्यानंतर तुम्हाला चेक करावे लागतील आणि रिचेक करावं लागेल. आणि सगळं हे झाल्यानंतर यू हॅव टू बी पर्सनली प्रेझेंट इन मेकिंग दॅट इन्सुलिन ड्रिप, इन्सुलिन इन्फ्युजन कसं चालू करते सिस्टर, व्यवस्थित तुमच्याकडे तो इन्फ्युजन पंप आहे ना, हे सगळं बघावं लागेल. सो थिअरॉटिकल पार्ट इज ॲट वन साइड अँड प्रॅक्टिकल आस्पेक्ट इज ॲट अदर साइड. सो दोघेही चॅलेंजिंग आहेत. थिअरॉटिकल पार्ट इज विथ यू, मायन्यूट कॅल्क्युलेशन करायचे, आणि प्रॅक्टिकल पार्ट इज ऑल्सो विथ यू बिकॉज सिस्टर्स आर गोइंग टू फॉलो व्हॉट यू आर डुईंग. बट तुम्ही सांगितल्यानंतर सुद्धा सिस्टर ते डिलिव्हर करतायत का हे वारंवार बघायला पाहिजे. सो एवढं सांगून मी आजचं हे लेंदी डिस्कशन टॉपिक संपवतो. सी वाय आय चोज दिस टॉपिक, आय एम टेलिंग यू. One day I came with a child who was having like very like 500-600 grammar, and then suddenly day 17-18 a child was all right, बरा होता 10-12-15 दिवस. Then suddenly started losing weight. I was not that knowledgeable that time. त्याचं वजनच कमी व्हायचं. सिस्टर म्हणायचे सर 10 ग्राम कमी झालं. पहिल्या दिवशी मी बोललो ठीक आहे काय नाही, दुसऱ्या दिवशी पण बोललो काय नाही, बिकॉज बाय दॅट टाइम द चाइल्ड वॉज ऑफ IV फ्लुइड, ऑफ अँटीबायोटिक, फक्त रेस्पिरेटरी सपोर्ट आणि न्यूट्रिशन चालू होतं. मला कळेच ना. 3-4 दिवशी म्हटलं अरे एवढं वेट लॉस होते तर सिस्टर एकदा जस्ट शुगर तर कर. अरे शुगर दॅट टाइम वॉज 550, 550 शुगर आल्यानंतर मी एकदम डिस्टर्ब झालो. ह्याला फोन कर, त्याला फोन कर, सगळेजण हेच म्हणतात अरे सेप्सिस होगा. अरे म्हटलं अरे तू उसका सेप्सिस बोल रहे तुम, पर उसका ब्लड कल्चर निगेटिव है ना. नहीं रे नीलेश, वो सेप्सिस ही होगा, तू देख ना पहिला, तू फंगस चालू कर ना, वो अँटी फंगल होगा, तू ये चालू कर. अरे पण कोण पण मला बोललं नाही निलेश तुला ना इन्सुलिन ड्रिपचा विचार करावा लागेल. यू गो हेड अँड यू स्टार्ट कॅल्क्युलेटिंग रिगार्ड द इन्सुलिन. मग मी सोपं काय केलं, वाडियाला फोन केला आणि पेशंट वाडियाला शिफ्ट केला. त्या दिवशी मी ठरवलं की मी एक हायपरग्लायसिमियाचं प्रेझेंटेशन देणार, बिकॉज दॅट चाइल्ड अल्टिमेटली दॅट चाइल्ड वॉज बॅड हिअर ओनली. तो DICत गेला हायपरग्लायसिमियामुळे. अरे ते हे चालू कर, TG सायक्लिन चालू कर, हे अँटीबायोटिक दे, अरे नाही ते इन्फेक्शनच आहे. बट इव्हेंच्युअली आय रिअलाइज अननोटिस हायपरग्लायसिमिया लिडिंग टू हायपर ऑस्मोलार स्टेट, डायुरेसिस, DIC, आणि ते विचार 500च तर माझी काय नाहीच आहे कॅपॅसिटी फ्रँकली, पण पेशंट सांगत होते म्हणून मी प्रयत्न करत होतो. पण नंतर ते बाळ तिकडे पण वाडियात जाऊन पण सकंबत झालं, बिकॉज आय लॉस that much period in managing the hyperglycemia. See, this situation you will come once in your lifetime, but at least you know theory part. काय करायचं तो ऍटलिस्ट नो की बाबा माझ्याच्याने काय होणार नाही. यू कॅन टेल रिलेटिव्ह की बाबा मला इन्सुलिन असं द्यायचं, हे काय इथे जमणार नाही, तुम्ही वाडियाला जा. ऍटलिस्ट वी कॅन बी दॅट मच ऑनेस्ट. पण मला हे माहीतच नसेल इन्सुलिन का द्यायचं, कसं द्यायचं, किती डिफिकल्ट आहे, तर मी पेशंटला काय सांगणार, का ट्रान्सफर करायचंय बाबा. त्यामुळे लॉंग बॅक इट इज अ स्टोरी 3 years बॅक की मी ठरवलेलं आणि मी अनुराधाच्या किती मागे होतो, अरे मला हायपरग्लायसिमियाचं दे, नाही माझ्याकडे वेळ नाही, नाही नाही माझ्याकडे वेळ. अरे म्हटलं माझं प्रेझेंटेशन तयार आहे, हायपरग्लायसिमियावर मला बोलू दे. नाही रे, आता सगळे झालेत, तू 2-3 महिने थांब. आणि नेमका पावसाच्या वेळी जेव्हा सगळे बिझी आहेत, कोणाला प्रेझेंटेशन करायचं नाही, निलेश आहे रे एक स्लॉट. मी म्हटलं अरे मला हिने कसं काय स्लॉट दिला, 2-3 महिने तर स्लॉट देत नाहीये, ह्यावेळी कसं काय स्लॉट दिला. मग लक्षात आलं अरे कोणच नाही, सगळे आपापल्या ओपीडी.
असं असं अजिबात नाहीये. वी
असं नाही,
वॉन्ट टू लर्न फ्रॉम यू, सो वी हॅव गिवन यू द स्लॉट.
असं
असं
आहे का?
अजिबात
मला
नाही
वाटलं
की कोणी
आता
नाही म्हणून
पावसाच्या,
तुम्हाला बोलवलेलं
नाही मला वाटलं
आहे.
पावसाच्या सीझन
डॉक्टर
मध्ये सगळे.
निलेश, यू हॅव डन अ व्हेरी गुड जॉब. आणि आय थिंक वेन यू टीच एव्हरीबडी यू लर्न मोर.
येस.
दॅट इज व्हॉट इज व्हेरी इम्पॉर्टंट फॉर ऑल ऑफ
हा
अस.
पण मला स्लॉट उशिरा मिळाला, हा 3 महिने लागले.
ते आम्ही अनुराधाला सांगू आता.
मला
पण
वाटतं पालघर अकॅडमी ऑफ
थँक्यू
एकदम,
सो मच.
हा फॉर्म मध्ये आहे त्यामुळे मला वेळ लागतोय. मॅडम ऐका ना, माझं
हा.
पर्सनल असं आहे ना, ऑनलाईन मध्ये ना लोक बऱ्याच वेळा नाही देत, तर मला ना तुम्ही पुढच्या वेळी ना ऑफलाईन काही द्या. काय होतं माहितीये का मॅडम, इंटरॅक्शन चांगलं होतं आणि ना ते नंतर फॉलो होतं. ऑफलाईन मध्ये काय ना, मी एवढं प्रेझेंटेशन करतो, मी एवढं सांगतो, मग ते काय नळी फुंकले सोनारे, इकडून तिकडून गेले वारे. म्हणजे
असं काही नाही, वारा पण जात नाही, पण
Nilesh, what you
सोनारांनी
spoke was
काय
very good.
टोचले पाहिजे ते तुम्ही
हा
टोचले
पण मॅडम
आता.
मला ऑफलाईन मध्ये टाका जरा कधीतरी,
येस येस,
है ना.
डेफिनेटली.
हा लक्षात
येस
ठेवा मॅडम,
येस.
पुढचं मला ना मेटाबॉलिक अल्कलोसिस वर पाहिजे, आणि दॅट आय वॉन्ट टू डू ऑफलाईन. वेन एव्हर यू से आय एम गोइंग टू डू ऑफलाईन. हा मी आत्ताच सांगतो, बिकॉज
येस
मेटाबॉलिक अल्कलोसिस इज ऑल्सो नॉट डिस्कस मच. सो
येस.
नेक्स्ट माय टॉपिक इज मेटाबॉलिक अल्कलोसिस, अँड दॅट इज ऑफलाईन. दॅट इज माय डिमांड.
अंजली, यू वॉन्ट टू से समथिंग?
Yeah, Nilesh, very good presentation and so many points that we can take home. I just wanted to add that we were very liberal with use of lipids, and the only problem I realized with lipids is that we have to be meticulous with our asepsis, and that is the reason we used to hesitate earlier. But now I don't do NICU, but when I was doing, we were giving and up to 3 mg per kg as well.
मॅडम ठीक
And
आहे, ठीक आहे.
that was one thing. Yes, we have seen hyperglycemia, and we also used to keep a cutoff of 250. And sometimes in premature babies, if we give just 5% in a TPN, then weight gain is not good, and the anabolic state is not achieved. So we used to go up to 10, and then we used to see hyperglycemia, and then we had to give insulin. So we have seen a very good response. And the only thing after giving insulin is that we are more worried about hypoglycemia after that. And we have to be really meticulous and up to our mark in that. So thank you for this very good presentation.
थँक्यू.
And even amino acids. So in IUGR and very sick babies, we used to start partial TPN on day 1, and very preterm babies like 1.2 and less, we used to start lipids on day 1. So we were very liberal with that use because we did realize it makes a difference.
Thank you so much, Dr. Anjali, for your practical tips. And Dr. Nilesh, you have done a wonderful job.
Yes.
Thank you so
Thank you.
much. And we will definitely have an offline session with you. Let's see when it happens.
Hemant Joshi sir.
Yes. हेमंत जोशी सर,
हो,
तुम्हाला
हो.
बोलायचंय?
निलेश, घर का
बोला.
हायपरग्लायसिमिया हायपोग्लायसिमिया बरोबर. आणि तू ऑफलाईन म्हटल्यावर खूप लोक ऑफलाईन चालले गेले. तू सांगायला पाहिजे होतं की आता बंद नका करून, मी येऊन सांगणार आहे.
The problem with offline is की participants पण hyperglycemia होतं.
तर शुभस्य शीघ्रम तुलाच ऑर्गनाइज करायला लागेल.
हो.
ऑफलाईन करूया.
नाही
त्याला
मॅडम,
आपल्याला काजू
अनुराधाला
खायला
सांगायला
मिळतील.
पाहिजे सर.
ऑफलाईनचा फायदा असा की काजू खायला मिळतील.
हा ऍटलीस्ट
वेट
सर
पण.
वन्स इन अ इयर ऑफलाईन व्हायला पाहिजे.
येस येस.
Nilesh, we
निलेश
have
छान
many
झालं.
offlines. Please do come
निलेश
for
छान
them.
झालं. या छान झालं निलेश.
थँक्यू मॅडम.
So, thank you so much, Dr. Nilesh. And our next speaker is a dynamic doctor from Amravati. He is a founder president of Indian Medico-Legal and Ethics Association. He is a founder of Human Milk Bank Association. He has given many prestigious orations, including the D.B. Shirole oration. He is the editor of the textbook of medico-legal issues, which everyone should have in their own connection and read it. He is the founder editor of New Indian Journal of Pediatrics. He has many awards and research papers under his able leadership. Let us learn what every doctor should know when medicine meets the law. I welcome Dr. Satish Tiwari sir for
Namaste,
giving
madam.
his oration on the session, which is very important.
Thank you, Dr. Jayashree, madam. And thanks, Palgar Academy of Pediatrics, for organizing this CME. And as Dr. Nilesh has said, now most of us are busy with the increased number of pediatric cases in the community. So the I think the problem which Nilesh said, I think that timing is not during the OPD hour, so that is the best thing. So many of us could attend. And now in next 45 to 50 minutes, I will be discussing some very important issue which we face in day-to-day pediatric practice. And though we all know that the patients are there and sometimes the complications are there, but we have to be very careful in selecting the patients, and not only selecting the patient but also the investigation and treatment, as Dr. Nilesh has already said. So my today's talk is dedicated to Lady of Justice. And if we see, the Lady of Justice in India has changed from the old Roman Lady of Justice, which she had a cover on her eyes. So we used to say that the judiciary is blind or the law is blind. But now we have Lady Justice of Bharat, which says that the judiciary has open eyes. So we have to discuss the things now in this context also. As far as children are concerned, there are different documents or agencies which include the International UN Convention Right, then human rights, the Protection of Human Right Act, our Constitution of India, Indian Penal Code, and now we have the Bharatiya Nyaya Sanhita from 2023. And of course, then we have the Consumer Protection Act, and of course, the National Medical Commission and various state medical council who are looking into the rights of each and every child. So with all these documents, we have to keep in mind, and why should know all this, because patient or the relatives or the parents can go to different courts, to the different councils. So from state council to National Medical Commission, then district consumer court to the state and national medical commission, National Consumer Commission, and of course the various criminal decisions. If we look into the medico-legal cases, now before we go into the details of the various cases, let me explain one thing, that whatever we are going to present in next 40 to 45 minutes, people say that the situation is very frightening. But as a medico-legal consultant, I would like to convince all of you that though the situation is frightening, but we should not get frightened, because if there is some problem, the court judgments, and of course, we are there as a medico legal consultant to guide you. And the problem may not be that severe as we think before we face any such situation in the life. Now, this is analysis of about 250 cases which have already been decided by National Commission. between 2015 to 2019, so almost 5 years back, this was the situation. I personally feel the situation is same, but last week we had the representative from Maharashtra Medical Council, and he said that the cases against pediatrician are increasing. But if you look at these cases, of course, these are last 10 years, before 10 years, 15 to 19. The cases were maximum against surgical, obstetrician, orthopedic branches, and only about 2% cases against pediatrics. Now, one of the reasons which we analyze for this is that in pediatrics, usually we give guarded prognosis. So I think that is very important carry home message from this slide. Though the cases might be increasing against pediatrician, please remember whenever patient comes to us, we should give guarded prognosis. We should say that we guarantee for the care of the child and not for the cure of the disease or the illness. So guarantee for care and not for the cure. If you look into state-wise cases, in 2000, the number of cases in Maharashtra were, if you look at this, the Maharashtra was at the bottom. But gradually, in 2016, the number of cases in Maharashtra is increasing, and we are now much ahead in our country. One of the reason might be that Maharashtra has more people who are aware of the medical legal cases, and of course that they are more educated and they have more of a knowledge, maybe from Google, but they are more knowledge, so they are putting more cases. This is one of the important case. The judgment is old, again of 2000, year 2000. But this principle will apply at present also. This was the case Bapu Kople versus Dr. Batambre. It's again from Maharashtra. There was an allegation that the doctor could not do proper diagnosis, so diagnosis was wrong. Investigations were not done, and there was delay in blood transfusion. But in this case, the opinion was taken, and according to the doctor, we could explain in the court that the child, when he came, he was serious. Probably he was suffering from septicemia. And if we wait for blood culture, so it takes long time. Maybe if you do sensitivity also, then it takes 2 to 3 days. So in this case, antibiotics were started, and the treatment for malaria, which was one of the differential diagnoses, was continued. If the child was in shock, the blood transfusion also takes at least 3 hours. In this case, the patient has succumbed within half to 1 hour after coming to Dr. Bhattambare. And then the Dr. Bhattambare also produced a certificate from the then civil surgeon in his city that the treatment was proper. So a medical board or expert board, if it gives that treatment was proper, usually most of the court cases will be decided in favor of the hospital or the doctor. So in this case also case was dismissed, that there is no deficiency in service and no negligence in diagnosis or treatment of the patient. As against this is 2012 judgment of National Commission, where again there was allegation of wrong treatment. The cerebral malaria was misdiagnosed as the clinical and blood tests were not done, so investigation was not done. And IV quinine was given without taking due care. So as Dr. Nilesh has said, while giving IV insulin or IV glucose, we have to be very careful. And here the IV quinine was given without taking due care and without ruling out the adverse reactions. So you have to be carefully monitor whenever you are giving any IV drug. Very extensive or very careful monitoring is required. So in this case, according to National Commission, there was a medical negligence. 3.25 lakhs were sanctioned as a compensation with 6% of interest. Another National Commission judgment where a child with syndactyly was undergone for a operation which was under 4 stages. So at one time, all the fingers could not be separated. So gradually under 4 stages, the hands and fingers of left foot were separated. 2 fingers of right foot could not be separated due to absence of fallings. So there were no fallings in those fingers. So those could not be separated. And according to the doctor, the further separation could have resulted into the gangrene. So this was explained, and ultimately the National Commission said that the negligence is not proved, and this case was filed as a baseless or abuse of the law, and the case was dismissed by National Commission. Another interesting pediatric case where a 10-day-old child with septicemia, there was infection as injection site or IV site, which gradually resulted into gangrene and auto amputation of the hand. This case, as we have seen the previous few cases, the doctor could not explain, could not give proper reason how the auto amputation and how the gangrene has happened. So this case was taken as a case of res ipsa loquitur, which means that the things are so obvious that there is no need for any expert evidence to be produced, neither by the patient side nor by the doctor side or the hospital side. So such cases come under the principle of res ipsa loquitur. And here the doctors along with the nursing staff were held guilty. 2 lakhs were sanctioned again with 6% of interest. This is 2007 case, so almost 18 years. But why we are discussing? Because this principle will persist in present years also. Another interesting case, this is from Kerala 2009 judgment, where patient was shifted to a newly constructed block. So new construction was there. Many things were not fully constructed, so some of the material was pending here and there. The proper painting might not have been done, the clearing was not there, so atmosphere was polluted with dust and other materials, resulted into staphylococcal infection, and patient deteriorated and expired of the multi-organ failure. So here in this case, the court says the hospital failed in keeping premises in hygienic condition and compensation was awarded. So as discussed by Nilesh, Dr. Nilesh, especially in neonatal period or in PICU, we should be very careful that our setup is clean and hygienic. A very interesting case again, judgment of 2015, where a full-term LSCS 3.1 kg baby, he developed jaundice on the 4th day of life. So that means most probably it was a physiological jaundice. But baby was separated from the mother and he was shifted to NICU without mother. Mother's milk was not given. The powder milk with bottle feeding was done. And the child omitted, resulted into aspiration pneumonia, ultimately septicemia, multi-organ failure, and the baby succumbed. Again, such cases, why full-term child on the jaundice on the fourth day, which can be physiological, and why he was shifted, that too without mother, and the mother's milk was not given. So it is really very difficult to defend in the court of law. In this case, again, the compensation was awarded against the doctor. Another interesting case, though it is 2004 judgment, but it is a National Commission judgment, and most of the things remain same even today after 20 years. In this case, the first baby was thalassemic. So when the mother was pregnant second time, she went for prenatal diagnosis for thalassemia. The test done antenatally, the test came to be negative. At that time, probably this test was not done in India, so the sample was sent to UK for antenatal diagnosis of thalassemia, and the report came negative from the UK. So when this case went to the court of law, that we had done, and we were told that the baby is not thalassemic, but after birth the baby was found to be thalassemic, and the parent went to the consumer court. So here the National Commission, please remember this is National Commission judgment, and according to National Commission, the process of prenatal diagnosis is complex. The genetic technologies have not developed to the full extent, and this is applicable at present also. All genetic illnesses or inborn error of metabolism may not be very easy to diagnose. There may not be such diagnostic techniques, may not be free from all the errors, and National Commission also said no scientific technology can be 100% perfect. So there can be negative diagnosis or underdiagnosis or overdiagnosis, everything is possible. And according to National Commission, this error is inherent in nature and multifactorial. So any antenatal diagnosis, inborn error of metabolism diagnosis, or any genetic illness diagnosis may be multifactorial. So it's not a single factor that it was fixed. And according to National Commission, there is a very thin difference between error, imperfection, and negligence. So anything, any wrong diagnosis which was not where all the procedure was followed properly, we cannot have the allegation of medical negligence. The another interesting story from the pediatric patient. This is 2003 judgment where the child with rising bilirubin was there and blood tests were not done at proper time. So whatever, please remember from today onwards, if there is any suspicion of pathological disease, then we should investigate, at least do basic investigation, and depending upon what is the report, then we can plan for the sophisticated or newer investigation. So in this case, blood test was not done at proper time, proper phototherapy was not given, the patient was not referred to a proper hospital at proper time, so there was a delayed referral, and the treatment, overall treatment was not according to the accepted norms by a qualified pediatrician or the Association of Pediatricians. So please remember, from today onwards, we should have clinical diagnosis, then send the relevant investigations, give the accepted treatment, and then of course, if it is not possible to treat our place, then only we should refer the patient. In this case, there is permanent disability, and then 4 lakhs were sanctioned with 9% interest at that time. This is 2003. Another 2003 case, Gujarat State Commission judgment, where the Injection given by a general practitioner was faulty. The left leg got paralyzed. Doctor could not explain how, if the injection was given proper, why the leg should get paralyzed. This was again taken as a case of res ipsa loquitur. And the very interesting judgment, though this is of 2005, again I think most of the things will still be same. There was allegation of negligence in case of a post-operative death. Now the court says in this case, suspicion, however strong, is. So relatives may have very strong suspicion that doctor was negligent, there was deficiency in the service, but this cannot be ground to presume negligence. The court went on to saying life and death is in the hands of the God, and only because the patient or the relatives feel that there is deficiency in service or negligence, we cannot have the deficiency proved in that particular case. So there has to be expert evidence which should be produced by the child or the parents or their relatives. So in the absence of expert evidence, many times the decision will go in the favor of doctor or the hospital. So in this case, the case was dismissed by the court. These were some of the important decided cases with important principle like proper treatment, proper investigation, and of course the principle of res ipsa loquitur. Now we are going to discuss some of the very interesting cases. Rather than interesting, I will again say that after going through this case, you may feel that the medical practice has become very frightening in the present era. But my suggestion would be not to get frightened and be aware of the increasing medical legal or the negligence cases. This case is at present in the consumer court, so not decided. A full-term LSCS child, 3.1 kg, had birth asphyxia. All the resuscitative measures were done and the child was resuscitated. But because of birth asphyxia, he developed convulsions. Then there was regurgitation, aspiration, septicemia, again multi-organ problem. So in this case, gastrostomy was also done because there was regurgitation of the fluid. Final diagnosis is HIE, gastroesophageal reflux, and ultimately growth failure because of all these problems. Allegation of deficiency in service and medical negligence. But see the amount of compensation which has increased in last 15 to 20 years. The compensation asked in this case is 11.45 crores. Now the next question comes in our mind because IMA is fighting for this on capping of compensation. We as a medical legal organization are fighting for the capping on the compensation in medical legal cases. But unfortunately, the things are not going in right direction, and the 11.4 crores, 7.5 crores for future medical expenses of a mentally retarded and growth retarded child, 1.5 crore to the parents who are IT professionals for their loss of work and earning, 2 crores to the family for mental harassment, 35 lakhs for the present expenses or the treatment which they required, 10 lakh for legal expenses and other expenses. Now see what we can say, but here the parents have asked for the parking charges, the breakfast which they had to take while taking the child to the hospital, the lunch and dinner, etc. And not only this 11.45 crore, they want any other relief by the court. Another case where a preterm 28 to 33 weeks baby 1.2 kg who had many other complications developed a retinopathy of prematurity, and according to doctor the ROP screening was advised on 4 occasions including at the time of discharge. Ophthalmic exam was done once, and after discharge the parents did not follow up with the ophthalmologist for the treatment of ROP. So now the allegation is ROP screening was not advised, neither it was done in the hospital, and the compensation ask is again 11.96 crores. The breakup of this 11 crore is 1 crore to the mother, primary caregiver for a blind child, 3 crore for the future education expenses in special school, 2 crore for nurses or external medical help, 1 crore for various selective devices or equipment which may be required throughout the life by a blind child, 2 crore for other medical expenses for sustaining the life, 2 crore for loss of future prospects, and 25 lakhs for pain and suffering. This third case is really interesting, where there is no damage to the child. Here only simply the expiry date vaccine was administered. As we discussed, there is no damage to the child. So if there is no damage, usually it means that there is no medical negligence. But still the parents have allegation of deficiency in service, medical negligence, and the compensation asked again you can see 7,700 rupees for cost of vaccine, the hexavalent vaccine, 6 crores for treatment required over next 17 years. According to parents or according to this petition, what we feel that patient is still feeling or the parents are still feeling that complication can occur till 18 years. So child is now 1 year. So over 17 years, many complication can occur, and for that they want 6 crore and 5 crore for mental agony and stress. And the mental agony and stress is to the parents without even a simple damage to the child for last 1 year. We got a when we were discussing about how to defend this case, we got this very interesting judgment from Delhi Medical Council. It's Delhi Medical Council decision where again a case was of expiry date vaccine and allegation of medical negligence. The parents or the relatives filed the case in front of Delhi Medical Council, but they failed to appear before the expert committee in spite of a notice was served to them. What has happened in this case? The child was February 2015 birth, and he was given the 16 or 18 month dose in July 2016. And probably the dose which he was given in the first 3 doses, the 6, 10 and 14 weeks, the same vaccine was continuing with that doctor, and it has expired 3 months earlier. So the defense was that vaccine is bound to cause immune response like fever and febrile convulsion, but it does not cause any harm or morbidity to the child. And as per the scientific literature, if expired vaccine is given to any child, only option which is genuinely required is to repeat the dose after 4 weeks. And all doubts or concerns of the parents were removed by the doctor after the matter was diagnosed. So according to Delhi Medical Commission, the whole episode is just a misinterpretation and nothing else. There is no medical negligence. However, the Delhi Medical Council has advised Dr. Virmani to follow proper recommendations and guidelines in future. So no compensation was awarded, not even 10,000 or 15,000 was given. Dr. Virmani was only given instruction to follow the proper guidelines and recommendations in future. These are some of the medical negligence cases related to various things. But as discussed, we have to be very careful, especially if the child is premature or low birth weight, where there is possibility of two important complications. One is the retinopathy of prematurity, and second is the developmental delay or the lifelong mental handicap, growth failure. So these two things we have to keep in mind. While treating any patient, we have to be careful about the minimum investigation, the proper diagnosis, the accepted mode of treatment, and of course the proper referral at proper times. And the third important issues which we discussed is of diagnosis of genetic disorders or inborn error of metabolism. So that is also where we have to be more careful, especially nowadays with fetal ultrasonography or fetal echo. We have to be careful about the congenital anomalies which may be missed during antenatal period and then are diagnosed after the birth of the child. And last but not the least is the IV fluid giving and not having proper monitoring. So there can be extravasation, there can be overdose, and the side effects and extravasation resulting into abscess or gangrene and subsequent complication. So I think if these 4 or 5 aspect of the medical practice, if we keep in mind, the number of cases are definitely going to decrease against the pediatrician. And while doing all this, we have to keep a proper record. So proper documentation, informed consent is important. And in cases of serious patient in NICU or PICU, we can have daily or twice a day informed consent depending upon the progress of the child. So if he is deteriorating, we should go on telling morning and evening or at least once in a day that the child is not improving in spite of all the treatment and is continuously deteriorating. And as I said, we should guarantee for care and we should not guarantee for the cure of the child. Then we come to some very another important aspect, the cases of which are increasing by leaps and bounds, and that is the POXO Act 2012. And next 7 or 8 cases which we are going to discuss, they are again not the decided cases, but these are the queries that has come to our colleagues. If they were under such situation, the police party called them that such and such case has occurred at your place and you have not done anything or you have not followed the law of the land, that is the POXO Act. So these are genuine cases, but no problem at present to our colleague. And another thing which is related to protection of women at workplace is Visakha guidelines. So if the girls are more than 18 years and they are at workplace where there is a sexual harassment, then Visakha guidelines will be applicable. So these are again the guidelines given by the court. So these two acts we have to keep in mind while dealing with any female child or female patient. Not only this, there is a, according to the Protection of Child Right Act 2005, there are children's court or the courts for the children where the cases or offenses against the children are to be taken on a fast track basis or speedy trial. The discussion will be in camera trial so that there is no embarrassment to the child. And of course, we have these different child helplines 1098 and 112, which is available 24/7. We should inform if we find anything wrong is happening to the child. So as we all know, the sexual harassment and abuse is increasing, and that's why the POXO Act was formed in 2012. Now, this is a first case. An 8-year-old child was admitted in our hospital, in our medical college, for fever and dysuria. While examining, we noticed some redness on the thighs, inner thighs, which were tender on touching. And the child started crying badly. When we took detailed history, the child was abused by the stepfather and the mother, who had married again with this stepfather. She was knowing all this, that her husband is abusing the child. So this was admitted with in our medical college, and the next thing which we did, we informed the police. Now we will ask what are the issues, why this case was informed to the police, or if such case comes, what can be the issues in such cases. The issues, most of the times parents are not interested in informing the police. In this case also, mother did not want that we should inform the police. The second issue is when the mother was knowing, whether she should have informed the police that my new husband is giving trouble to my girl child from previous husband. That was the second issue. In this case, parents were aware, so there is no need for doctor to inform. Is it that we can take the defense that as the parents were knowing, they have not informed, so we have also not informed. And the fourth issue is by informing the police, the doctor has put the family in the trouble. So now the police will give trouble to the entire family. Now the carry home message for all of us is that even though the parents were aware in this case, the case comes under the violation of POXO Act. And if the parents, the mother or the stepfather have not informed because he was the offender, it is our responsibility to inform the police. And whether by informing us, police takes action or not, that is a different thing. But if you do not inform the police after knowing a case of sexual harassment under POXO Act, then action can be taken against us also. Second case, this is from Mumbai area. I had once a phone call from one of our colleagues that a 4 to 5 year girl has come in shock. There was injury to the private parts. On detailed history, parents refused that there was sexual abuse. So they were saying that this all injury and trauma. But the doctor has high suspicion of abuse. So when he started taking detailed history about the abuse, the parents said, no, we are not willing to treatment from you. And they left the hospital. So before the child was admitted or the paper was made, the parents, they left the hospital and they went to another clinic. So the first doctor has not informed the police. The report was not sent to the police. Now, what are the issues in this case? How the question come to the, how the case came to the discussion? When the case went to the second doctor, probably he informed the police and subsequently the police have come to know. Now here the issues or allegations are, should the first doctor have informed the police? Should the second doctor inform the police? And should the first doctor feel that, okay, she has gone to some other hospital, so it is their responsibility now to inform the police? Or any of them can inform, and second doctor feels that it is not a case of abuse, so then he may not inform. Then the allegation will come directly onto the first doctor, that why you are not informed the police. To carry home message from this case is, we should always be vigilant and aware of the POXO Act. We should have high degree of suspicion, and it is our moral and legal duty to inform the police. The third case, 18-year-old girl with amenorrhea referred for USG to rule out gynec problem. So it was not suspected that she can be pregnant. So she was referred to for USG for ruling out the gynecological cause of amenorrhea. On USG, the sonologist find that she is 4 months pregnant, and the sonologist gives report that she is 4 months pregnant. Patient does not go back to the primary gynecologist, and to do the MTP, the patient was referred to the gynecologist in a medical college, where the medical college reported it to the police that 18-year-old girl is having 4 months pregnancy. So that comes under POXO Act. So radiologist or gynecologist who should inform is the first allegation or query. Is it the confidentiality issue? As in this case, parents were not aware that their child is pregnant. So should they be informed that your child is pregnant? The hospital, here the basic problem came when the FIR was lost against the hospital. That hospital was owned by a physician. So he was asked that in your hospital a case of POXO Act violation has come and you are not informed us. The hospital's owner's name was there in the charge sheet. Now, is this proper use of POXO Act? Should the hospital owner be involved in this, or it was not his liability, because he may not know each and every case is coming to his hospital? So whom should inform, radiologist or gynecologist? If there is something detected like this, discussed case with our colleagues, that means between the radiologist and gynecologist. Discuss with the hospital authority. So if the hospital was owned by a physician, we should inform him also. And any of these three people can inform the obstetrician, the radiologist, or the hospital in charge. Another case which we just discussed, an 18-year-old, as was recorded by the hospital staff. So 18-year-old girl came again with amenorrhea, and the age recorded was 18 years by the hospital staff. Boyfriend was also there and he was known to the family. Here the parents were aware that the girl is suffering from pregnancy and they came for MTP. MTP was done, which was uneventful. The products were disposed of by the hospital staff. Now for MTP or PCPNDT Act, there is a committee appointed by government who visit the hospitals under PCPNDT and MTP Act. And they found out from the Aadhaar card that girl was somewhere around 16 years age only. Then they asked the hospital that why you are not done all this, why you are not inspected the Aadhaar card, and why you are not informed the police. The primary consultant, those who were there in that hospital, they said that all this we have not done intentionally. We are not aware of the POXO Act, or we could not remember at that time that it is our responsibility to inform the police. So they started pleading that the mistake was done, but it was not intentional. The issues and allegation in this case, the act was in collusion with the parents because parents were aware that their child, unmarried girl, is pregnant. Can police register the case? Are parents also responsible in this case? Because they were knowing that the girl is pregnant, she is less than 18, and it was their responsibility to inform the police that my daughter has been assaulted sexually, because the boyfriend was also known to them. Now is girl responsible as a adolescent girl, whether it was her responsibility to inform that she had sexual relationship with the boyfriend? And what is the responsibility of the boyfriend, whether he should also know that having sex with a girl less than 18 years is prohibited under the POXO Act? Now, next question for all of us is this: in this case, will marriage change the legal situation or the legal issues? And primary physicians should again have been more vigilant, and they have not informed. So, carry home message: remember the POXO Act while dealing with any child who is less than 18, whether he is a boy or girl, because it is a gender neutral act. Better to be safe than be sorry. So, this applies again for all medical treatment. So, we should better be safe rather than be sorry subsequently, and inform the concerned authority. A 10-year girl with fever, she was admitted in a hospital, and after 4 or 5 days she became normal, so she was discharged. Allegation by the parents after the discharge that during the hospital stay, child was molested by one of the attendants. And they made a complaint to the police that doctor was informed by us during hospital stay that your attendant is molesting our child, but he has not taken any action. And after they went to the home, they filed a FIR against the doctor as well as attendant. The issues will be: was the doctor really informed by the parents and he did not take any action against the attendant? Does the doctor have power to investigate cases of POXO Act violation? Whether parents can directly inform the police that attendant in such and such hospital has molested our child, and what doctor should do now, because he is now his name is there in the chart sheet. These are, as I discussed, these are all actual scenarios which we are coming across in day-to-day practice. So again, our message is: be vigilant. You may not have power to investigate any such complaint by the relatives or the parents, but we can definitely find out the facts, what has happened, and we should inform the police, and then we should cooperate with the investigating authorities. Another interesting query which has come in the last week only from one of our colleagues, that as a receptionist or attendant, we are employing both boys and girls. And nowadays, the boys are complaining that the girls are very forward in the present era. They are very much overactive, including for the sexual behavior. And they are harassing us that if you do not have sexual act with us, or if you do not follow whatever order is given to us by the hospital authorities, and we do not want to do, and you do our work rather than we doing the work given by the doctors or the hospital, otherwise we will complain against you that you are harassing us sexually. So this is the problem. And one thing is here, the boys and girls, there can be some difference in the age. They can be less than 18 years also, or they can be more than 18 years also. But the allegation of sexual harassment is there. So according to the boys, we are under constant apprehension that this girl, receptionist or attendant can make any complaint against us because the laws are in favor of the girls. So boys are asking for the safety and protection from the hospital authorities or the individual doctor. The question that will come if such thing or complaints are made, are such issues happening in the hospital? Whom to believe, boys or to the girls? Whom the authorities will believe? Suppose the case is informed to the police, what police will do? They will still punish the boys, that girls are very simple and sober and they cannot do such type of activities. And will this come under the POXO Act or Visakha Committee guidelines? So the carry-home message, anything is possible in present era, and that's why the POXO Act is gender neutral act, because boys can also be harassed. It depends on the behavior of individuals. So any individual behavior is different. Nobody can guarantee what type of behavior that particular person will have. So as a doctor, our responsibility is to inform the appropriate authorities and again be safe rather than be sorry. Another query which I had received last week only, that a 18 to 19-year-old unmarried girl was employed in the hospital, and the doctor who has employed that girl later on came to know that girl is pregnant by 6 months. So unwed mother, which is in the borderline age of 18 to 19 years. The girl is not ready to give any details of the incidents when the sexual act has happened, whether the boyfriend was known or unknown, who is the abuser, whether it's some relative or boyfriend or some unknown person. So she is not ready to tell anything to the bus. Now in this case, is it a case of sexual abuse or rape? Does it come under the POXO Act? So is it a case under POXO? Is it a simple case of consensual sex? So this girl is though 18 years and 19 years and 6 months pregnant. So she had consensual sex at 18 and a half years because she is not giving any history. Now doctor wants to know whether after knowing all this, her behavior and her sexual behavior or not giving the informing about her behavior, should he expel or terminate that girl from the post of receptionist on moral ground? Again, will there be any issue of confidentiality? Can girl say that you have made everybody to know because you have disclosed that I am pregnant? Whether the doctor should inform that he has or she has removed on the ground of immoral behavior, that is getting unwed mother getting pregnant. And will there be a human right issue? If the girl is 19 years and she has pregnancy from her boyfriend who is also major, so it doesn't come under the POXO Act then. So it comes under the human right to have the sexual activity. Our message to that our colleague is again be vigilant, try to find out the actual fact, confirm the age of the girl before taking any action. We may ask her to leave the job, but whether to declare the cause for asking to leave the job should be declared or not. inform the authorities if we suspect anything that it may be violation of POXO Act or Visakha guideline, and of course maintain the confidentiality. Now last two cases, I hope there is a time or I have exceeded the time.
No, sir, we have time.
Okay, so only 2 or 3 cases. This is again a recent incident that occurred in Dinanath Hospital, Pune, was regarding the advance payment or advance charges. So can hospital take advance payments? Can charges be controlled or regulated by politicians, the government, the municipal authorities, or the charity commissioner, or any other authority who are associated with the medical establishment? So this is a judgment from the Mumbai High Court Nagpur bench, where the hospital association during the COVID period, they went for finalizing or restricting the charges of the hospital by the government. So there was government GR that the hospital should have fixed rates. Now in this judgment, the Mumbai High Court has said the charges and rates in any hospital can be fixed for a emergency or for a some public health emergency like it was corona at that time. So the government has right to fix the charges for the treatment of corona or any epidemic or any public health emergency. But the government is not competent to decide or putting a cap or regulating the rate chargeable by a private hospital for non-COVID patients. So our day-to-day NICU, PICU or surgical charges, as we have seen in that Dinanath Mangeshkar case, it was for a pregnant woman for the delivery. So in all these cases, the government or the authorities cannot fix the charge. It is a constitutional right of each and every doctor or the hospital to charge rates which are reasonable, proportionate with the nature and quality of the medical treatment. And this will differ from hospital to hospital depending upon the facility, depending upon the specialty. So very important case for us, especially after that Pune incidents. Now this is a very important case again for violence against the doctors or the hospitals. This is Kerala High Court judgment where the Kerala High Court says that it is not possible for doctors to manage each and every case, and if something wrong happens, the doctor should not be manhandled or insulted. So attacking doctors or staff, causing damage have become trend in our country. This causes great mental trauma and agony, and it shakes the morale and confidence of the doctors and the hospitals. So in this case, they have rejected anticipatory bail to the local leaders and the social workers who have created violence or problem in the hospital. So very important judgment again. Now, after all these case discussions, I think the main issue that remains whether we are getting really the justice or we are getting only the judgment or court orders in the various courts. So interpretation of law is very important for giving proper judgment. And because of this improper interpretation, the judgment or the orders go on changing from lower to higher court. The question that brings next to our mind is then if the judgments are going to change, up to which level we should go to the court. Suppose we are lost in district and state commission. Should we go to the national commission? Will we get the reverse judgment? Should we go to the district court or high court and then go to the Supreme Court? And is it possible and feasible for all of us? And if the judges cannot interpret, then what about the interpretation by common man? So how parents can interpret whether there is a something which is unlawful or which is negligence or not? So interpretation by authorities itself is doubtful. And of course, then the media interpretation and media trial is also important. So the ultimate question or ultimate answer which we are asking each and everyone, whether we are getting court orders, whether we are getting judgments in particular case, or we are getting justice in the court of law. And if we are not getting proper judgments, then what are the issues? The one of the important issue which we came to know during all this case discussion is that there are some legal or legislative vacuums in the laws. And because of this, there is different interpretation. And that's why we need regular amendments. But what is happening overall, there's causing a lot of confusion, paradoxes, and controversies. So all this we are discussing, as you know, through our Medical Legal and Ethics Association and the IAP Medical Legal Group and Chapter. These are our books on medical legal issues. This is our quarterly journal. So those of you who are interested or your colleagues who are interested in giving article in this journal, you can send the articles. This book is situation based. So particular situation, the problem and the solution. And we have a textbook also. So the ultimate question that brings, who is blind? Whether the authorities are blind, they are not making proper laws. Whether the judiciary is blind, who is not giving proper interpretation and judgment at each and every step. Or whether the parents or the relatives are blind, who are not able to see the proper treatment given by the doctor or hospital, or ultimately we are blind that after seeing all this in the present circumstances, we are not taking proper preventive measures. So I thank the Palghar Academy of Pediatrics again for giving this opportunity. And after completing the academic feast, academic talk, with the permission of Dr. Jayashree Deshpande Madam, I would like to do my canvassing. I am contesting for the post of EB from Maharashtra. So I request all your friends and you to request your friends and colleagues to vote for me when the elections will be there in the month of October. Thank you everyone again for the patient listen.
Thank you, sir. And we are the most eligible candidate, I feel. And we all the best for your future election as EB member. We would like to have your guidance in future webinars also.
Thank you.
There are some questions which people wants to ask. Dr. Suryakant Sankhi wants to ask a question. Sir, unmute. Sir, you have to unmute.
Ma'am, yes, sir. You can unmute now.
Sir, question to you.
Yes.
Wonderful lecture, sir. Question is, in our school, one of the school, it has happened that one of the parent has complained about the teacher. The teacher has asked for a friendship request from a 8th standard girl on a Facebook.
Yes.
And that girl accepted his request. And then he started asking her about her photographs and some chats were going on. So mother had come to the school.
Yes.
She didn't give a written complaint, but she complained to the principal.
Yes.
So, madam, such and such things are happening in your schools. So we asked the teacher, we summoned the teacher and we asked what has happened and why you asked for the friend request to the student.
Yes.
So he flatly denied that I have not asked for any request. My phone was hacked. So
Yes.
as a management person, I intervened and asked the principal to the teacher should go to the police station and lodge a FIR that my phone is hacked and I have not done anything. But unfortunately, the teacher never went to the police station. And when management asked him about written explanation, he didn't give a written explanation, and he suddenly stopped coming to the school. So, in such cases, what should be the stand of management and how to go about and resolve the issues with the parents?
No, I think there are 3 or 4 issues. I think this is a very good example or case. I think I will include this in our next presentation
Yeah,
also.
yes.
But there are 2 or 3 issues which I think in this case, the teacher was asking only for some friendship and uh, sending some academic messages, or there were messages which were related to sexual behavior.
So that we didn't get any photograph because
Yeah,
parents didn't show us. But
that is what I am saying. If it is a simple friendship request, then you can have friendship with anyone.
okay.
And if you are sending some messages which are related to academics, then
No,
also
no, no. They were not
there is
academic. They were
no
not
problem.
academic questions. He
Yeah.
was asking for a different photographs from that girl.
Yeah, photographs, but if the photographs are without means with minimum clothes or something in compromising position, then it is a different issue that will come under sexual harassment.
Yeah.
But if you are asking for birthday photo or something like that, or your photo of your some journey or tours, he has gone to some place along with the father, and then there. Because photograph asking, he can take photograph in the school also, no? So there is no issue with that. So what type of photograph he was asking, that is also important.
Okay.
So if from any source it is possible to prove that he was asking for some message or photographs with sexual intent, then only it will come under the POXO Act.
Okay.
But if it was not with that intent, then the POXO Act will not apply. Now, if the management is telling that go and complain about that the photo and that the phone was hacked, so that he can go for, if there is a genuine hacking, then it is okay. He can go to that.
Yeah.
If he has a feeling that if I go and tell that the
Police.
photograph, my phone was hacked, and then such and such parents are complaining, so something will come under POXO Act. So he also does not want to take the trouble from the police.
Okay.
So why, if that problem of hacking was over, why he should create his own problem by asking that the parents are now having allegation of sexual abuse of their child, and that's why I have come to you to investigate the
Case.
hacking part of my phone.
Okay.
I think that was a wrong decision on the part of management. Now there was no need to ask the teacher to go.
Okay.
Now there comes the third part. What management should have done? Management should have investigated at your own level. You should have asked the parent to show those messages or whatever he has sent if they have observed it. Otherwise, they should have continued that relationship of that teacher and student, and they should have waited for some fresh message
Okay.
which would have been sexually abusive, and then they should have lodged the complaint.
Okay.
So that could have been investigated. And once we come to know that there is a suspicion of sexual abuse, then it is our responsibility to inform the police. Rather
Okay.
than asking the teacher to go to the police, we should have informed the police that such and such thing has happened in our place. Then you can tell them that the teacher is giving us the reason that my phone was hacked. So it is now the responsibility of police
Okay.
to investigate the matter, whether he was doing with the sexual intent or his phone was hacked and somebody else was sending those messages. So then that is the responsibility of the police to investigate that.
Do we require written complaint from the parent or verbal request will be okay?
No, verbal request is okay, but they should give proof. Now, without that, you cannot go on investigating. If
Okay.
some parents come in future also, you can ask them, na, ki what is the complaint and what you are complaining of. So give in writing at least that,
Okay.
and give some proof of that message. Without proof, I think we should not go ahead.
Okay. Thank you.
Sir, can this be under the modified POXO Act?
No, madam, what we have discussed today is after the modified POXO Act only. 2020 or 19, I think it was modified.
Okay.
Thank you.
And what I learned from the session is that if a civil surgeon gives certificate that treatment was proper, then we should feel that the doctors are safe.
Yeah, madam, that time it was somewhere around 2000. That time civil surgeon would give. But nowadays present is that if there is any case where there is a doubt of medical negligence, the court or we can refer that case to the team of expert who will usually be a civil surgeon if it is a government hospital in that city. And if there is a medical college in that city, then the civil surgeon does not have the power. It will be the dean of that medical college.
Okay. Another thing is that since the capping on the compensation, we are trying for that, and it's increasing day by day. So, is the indemnity should also be increased?
Yeah, indemnity initially we were doing for 10 or 20 lakhs. Now we say to our colleagues that do minimum for 50 lakhs or 1 crore. And if you are doing really intensive care practice, then we suggest 2 crores also. Because we are doing indemnity for our colleagues. So after 2019 Consumer Protection Act, when the limit for the district was made that if there is a bill of 50 lakhs, then the care compensation, many people has doubt that the compensation will now be asked will be minimum 50 lakhs like that. So after that we started telling them that to go minimum for 50 lakh or 1 crore. But basically it is not for that. Now the cases for any amount usually will go to the district forum only. The problem with 2019 amendment is that now the patient can file case at his place also. Like if you are practicing in Mumbai and the patient has come from Amravati to the Mumbai for treatment, if he has some allegation, he can go back to Amravati and file a case in Amravati District Consumer Court. This was not there before 2019. Before 2019, if he had to file a case, the case has to be filed at Mumbai only.
But Dr.
Dr.
Satish,
Anshul.
Yes.
you said that you are asking them to file for 2 crores, but compensation indemnity, but the compensation they are asking for is 11 crores. So how will that ever be met?
No, madam, this is what patient or parents is asking. And the maximum given at present is 1.8 crores in ROP case from Tamil Nadu.
I see.
And second case, there was 11 crore against the Emory Hospital, Kolkata. That was 11 crore. But in that case also, it was against the hospital and not against the individual doctors. So for individual doctor, in that case also, it was 25 lakhs only.
But did the hospital pay 11 crores?
And they had to pay, na madam, usme kya hai? Because it was a Supreme Court judgment. There was no option. They cannot go to any higher authority now. It was a Supreme Court decision.
And like the case in which you said that the child was born with asphyxia, they
Yes.
did not take action against the obstetrician, they took action against the pediatrician.
That is very well possible, madam. Again, it was in a hospital, so hospital includes both obstetrician and
Okay.
And second thing, our suggestion is that if there is a case in the court of law, we should stop pointing fingers to each other. Means
Yes.
obstetrician saying that it was pediatrician fault, he did not came on
Yes.
time, or he did not know how
Do
to
something.
resuscitate the child. And the pediatrician should not say that obstetrician has informed me late. I would have gone earlier, so the outcome would have been different. She did not do early LSCS, or she went for forceps delivery, and that's why the baby had trauma and all those complications. So I think this will create more problems. So if there is a case against pediatrician, we can say that involve obstetrician also, because she is was responsible for the delivery of this child. But we should not say that it was the obstetrician's fault. So we should not point finger to it.
And also, I want to know, in case of asphyxia, or where we think that this child may later on have any developmental problems, for
Yes.
how long should that medical record be kept?
If there is a permanent problem, we suggest for 21 years, madam.
Okay.
Otherwise, for a routine patient where there is no lifelong problem or lifelong morbidity, then we can preserve it for 3 years from the date of discharge. So according to National Medical Commission, 3 years.
But if we suspect that there could be a lifelong problem, then up to 21 years.
And we should keep it for 21 years. Not all of our papers. So suppose we have 1,000 admission in our hospital in a month. So every year 12,000 paper, there is no need to keep it. Baby is normal. He has been coming for vaccination, so we are following him up. Growth and development is normal for 2 to 5 years. So I think around 3 years or 4 years we can dispose of those papers.
Very nice. All the cases you showed were very relevant to us pediatricians.
Yes.
We have to be really, really careful and vigilant.
And since you brought over the question of professional indemnity, so we have professional indemnity from our scheme. So I will send the details to Jayashree madam, and if you want, you can circulate it amongst your.
Yes, yes,
Please
Dr.
send.
Satish.
Yeah. And that's very important message today we got, that we have to be vigilant, and we have to vote for Dr. Satish Tiwari sir for EB member for Maharashtra, and his further journey. We wish him best of luck.
Yes.
And
Thank you,
today's
madam.
discussion was really nice. Dr. Nilesh also has given a very good insight about the hyperglycemia in newborn. And we have learned a lot from Dr. Satish Tiwari sir. Dr. Hemant Joshi sir, you want to say?
नाही नाही छान. थँक्यू ऑल.
We
खूप
have to
छान.
be very careful, especially in a girl child below or somewhere around the age of 18 years. It has to be very careful.
Sir, there's just one more query. A girl patient of mine, she was about 13, 14. She was sent to a neurologist for some epilepsy, and she came back and said that the neurologist molested her. Now, her mother refused to report it to the police or to the authorities. So,
Yes.
should we, as a pediatrician, report the police?
No, madam, again, I think the best thing which to do in this case, first we will have to confirm something, because molested means what?
He wanted to
has-
examine. He
If
wanted to
he has
examine the
ausculted,
breast.
if he was ausculted the heart sounds, then it is not molestation. If as adolescent girl, if he has examined for some endocrinal imbalance, which can result into brain tumor or some intracranial lesion and epilepsy, So then it will not be a molestation. So basically, first we have to find out what the person has done. And if that part of was not the part of his actual examination, then we can think of molestation.
Yeah.
And secondly, if he is examining the chest or the perineal area for any reason, like in adolescent girl, many times for the sex maturity rating or for this, we may require perineal examination. So this should be done under in the presence of a nurse attendant, female attendant, female nurse or female attendant. Then also the allegation of molestation will decrease. So all these things we have to see. Only because someone says that the particular doctor has molested me when I went to her, it cannot be. It can be a part of routine examination. So that has to be proved.
Okay. Thank you.
Thank you, sir. Thank you.
Okay, madam.
Sir, I have one
Yeah.
query.
Hmm.
We had one newborn with respiratory distress. Distress increased over a period of time, and we did this 2D echo and diagnosed as PPHN. Started with all the treatment of PPHN, sildenafil
Yes.
drip and all,
Yes.
and ventilated the baby, but baby did not improve. So we asked the relatives to take the child to higher center for nitrous oxide therapy,
Yes.
and they took the child. They we transferred. While transferring, we said it was, I think, early morning.
Yes.
So we said, you transfer the child and you can pay us later
Yes.
because it is emergency. And
Yes.
they went, the child went there, and child improved within a week, and they discharged. And
Hmm.
then we called the parents to pay the bill. They
Hmm.
said, we will come and pay, but they didn't pay. And they what they are nowadays, there is a new thing that they are writing Google reviews, and they wrote very negative and bad Google
Bad
review.
review about you.
Yeah, within 2 days they made, because child was on ventilator. Bill was of course very high. High means maybe 45 to 50,000 for 48 to 36 hours. And they said ki bill was very high. How he did the 2D echo and all, whether he is cardiologist. Actually, my husband is certified certified he's doing 2D echo and he's certified. So
Hmm.
he does, and he sends the pictures to the cardiologist in the midnight, and then we decide, take the decision and all. So they did a lot of allegations on Google review. So in this case, what we should do, they have not paid the bill, and they're doing
Okay,
lot of
so
allegations.
two or three issues which I have understood. First is, if you have any doubt that tomorrow they can go and file a case of medical negligence. I think it is now we are talking of human right. So they have every right to go and file a case of medical negligence.
But
But
there was no negligence, huh?
that is what I am saying. But this case will not stand in the court of law as far as negligence is concerned, because you have monitored for first 2 days or
Yes,
3 days,
yes, sir.
whatever you have done.
Yes, sir.
Then you refer to that patient. The
Timely refer.
patient went to a proper hospital where he was
Yes, sir.
treated,
Yes,
and
sir.
there is no damage. So now
No
there is
damage.
question of negligence case will not stand in any court of law.
And our paperwork is clear,
Yes.
proper.
Now second issue is of the your charges. So I think the best option with you is, now in this case you forget your charges,
Okay, sir.
and for
And
future,
what about their reviews, sir?
you have to remember. Yes, I am coming to that third point. For future, you have to keep what Dinanath Hospital has done. Do not admit any patient without taking adequate
Advance.
advance.
Okay, sir.
Even if this child comes to you subsequently after 2 months or 6 months or 1 year,
Okay.
they say last time आपने किया था, आपने एडमिट किया था, फिर आपने हमको रेफर किया, हमारा बच्चा पूरा अच्छा हो गया, तो यू मैनेज एंड देन वी विल पे यू लेटर ऑन। तो इस बार आप उनको एडमिट ही मत करिए, उनको बोलना भाई पिछले बार का बिल बाकी है, आप पहले इस बार एडवांस दो, देन ओनली वी आर गोइंग टू मैनेज योर चाइल्ड।
ओके सर।
ठीक है, दीनानाथ मंगेशकर वाले उसी बात पे बचे हुए।
ओके।
And third issue which you has raised about the Google rating or
Yeah.
online rating, I think madam उसको hardly it matters anything.
Yes.
गूगल पे रेटिंग देने के बारे में आजकल तो ये है ना, किसी को पैसे दे दो तो उसके बारे में लोग अच्छी रेटिंग दे देते हैं। इवन
Yes, that is
कंपनी
true.
पीपल, जो
I
कंपनी
know.
वाले वो ऐप चला रहे हैं, वो अपने 50 लोगों को बोल के वो आपके नाम से अच्छी रेटिंग डलवा देंगे, और आपने उनका ऐप नहीं खरीदा है, उनकी सर्विसेज नहीं ले रहे हो, तो 50 लोगों को बोल के
Okay.
उसकी रेटिंग खराब करवा देंगे। तो
Okay,
यदि
sir.
कोई पेशेंट भी कर रहा है तो लॉन्ग टर्म में इट इज नॉट गोइंग टू अफेक्ट योर प्रैक्टिस,
That
बिकॉज
is true.
if 5 or 10 people are giving you negative ranking, there are other people who are giving positive ranking for you also.
My question is, sir, whether we should send notice to him for defamation and
जून आपली मराठीत एक म्हण आहे, शहाण्यांनी कोर्टाची पायरी चढू नये।
okay, sir.
तो अपन खुद होके कोर्ट में नहीं जाना,
Okay, sir.
उनको यदि जाना है तो जाने देना।
Okay, sir.
देन विल डिपेंड
Okay, sir.
कि भाई आपका ट्रीटमेंट खराब थी, उसके कारण हमारे पेशेंट को ये नुकसान हुआ, तो देन वी कैन डिफेंड इट।
Okay, sir.
खुद होके कि भाई आपके कारण हमारा डिफेमेशन हो रहा है, प्लीज डू नॉट डू दैट।
Okay, sir. Okay. Thank you so much, sir. Thank you.
जोशी सर ने हाथ उठा दिया ऊपर।
सर एक डिफिकल्टी ऐसी है, अभी 5,000 मेंबर है ना अपन महाराष्ट्र में, या 50,000 ऑल इंडिया,
हाँ,
तो व्हाट इज द इंसिडेंस ऑफ मेडिको लीगल केसेस, 1 per 1,000, 1 per 50,000 पर ईयर, ऐसा हम बोलते हैं ना पर में, ऐसा कुछ है क्या
वो
पढ़ाई?
अभी स्टडी नहीं हुई है, बट जो डिसीजन आगे वो हमने बताया ना कि अगेंस्ट
वो तो हो गया, वो तो केस स्टडीज हो गया, पर समझो तो समझो 5,000 लोग एक साल प्रैक्टिस करते, 5,000 एन ईयर हो गए, तो उसमें इंसिडेंस पर ईयर कितना है महाराष्ट्र का, या ऐसा?
हर
महाराष्ट्र
हर पीडियाट्रिशियन पे कोई ना कोई केस तो है एट डिफरेंट लेवल।
तो 5,000 महाराष्ट्र में 5,000 केस है, ऐसा?
5,000 केसेस तो है ना, कोई प्रॉब्लम।
क्या बात है।
किसी को मेडिकल काउंसिल के अगेंस्ट में होंगी, मतलब
हाँ,
किसी के अगेंस्ट में मेडिकल काउंसिल में होगा, किसी के अगेंस्ट में डिस्ट्रिक्ट कंज्यूमर में होगा, किसी के अगेंस्ट में, बट पूरे
आपका
महाराष्ट्र में
जितनी
5,000,
केसेस, सुनता
पूरे
हूँ
महाराष्ट्र में 5,000 से ज्यादा केसेस होंगे डेफिनेटली।
पीडियाट्रिशियंस पर।
यस यस।
अच्छा, यानी जितना केसेस ज्यादा उतना तुम्हारा स्टैंडर्ड ज्यादा, स्टेटस अच्छा है, ऐसा
नहीं,
बोलना पड़े।
वैसा नहीं है, जितने केसेस ज्यादा उतना आपको
Right.
उनको, आप या तो डर रहे हो उनसे पेशेंट से, या आप उनको थोड़ा मौका दे रहे हो केस करने का।
जी जी जी।
उनको बताओ हमारा सब बराबर है, तो देन दे विल नॉट मेक ए केस।
Last I want to tell something to all our
Communications
colleagues.
हाँ।
कि highest cases are for jaundice patients. Waste में तो if you are treating children with jaundice, your insurance premium rises. So be careful with every jaundice patient you admit or treat.
फिजियोलॉजिकल जॉन्डिस, नियोनेटल जॉन्डिस की बात कर रहे हैं कि?
हाँ, जो मतलब maximum cases on pediatricians are done by parents of children who had jaundice. ऐसा अभ्यास
Neonatal
है।
jaundice.
हाँ, neonatal jaundice.
नियोनेटल जॉन्डिस में जनरली प्रॉब्लम नहीं आती, प्रॉब्लम कम्स विथ आरओपी बिकॉज इट इज ए परमानेंट डैमेज, or if there is a low birth weight child and a neurological deficit or growth failure,
True.
then it is difficult to defend. क्योंकि उसमें कैसे बच्चा मरता नहीं है, और वो हैंडीकैप्ड बच्चा उनको जिंदगी भर दिखता है।
सही बात। हमको एक केस हुई तो इतना हेडेक होता है, आपको कितना हेडेक होता है? पूरा दुनिया का हेडेक आप संभालते हो।
मैं बता तो रहा हूँ, अभी पिछले एक दो महीने में पॉक्सो की बहुत क्वेरीज आ रही है।
आई नो। चलो, भगवान की दया आप है हमारे लिए, बहुत
Sir,
धन्यवाद।
please share your number and website and your phone number so that those people who want to communicate with you, we can send this number to in our group.
Yes, yes. Okay, madam.
Yes, sir. Thank you so much.
Okay.
And
Thank you.
all
All
the
the best.
audience, thank you so much for attending. It was really interesting because of your discussion. Thank
We
you.
will vote for you.
Yes,
Okay.
definitely.
Thank
Palghar Academy is with Dr. Satish Tiwari, and I am really happy that he is the part of our self-defense workshop everywhere. He tells about the legal aspects in the self-defense session. Thank you so much for that, sir.
Thank you, madam.
Thank you.